He is not live. Ahmed, we start? Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to SAPH 2024 pre-conference workshops. We have today three very good workshops, starting with imaging and pulmonary hypertension. And we have today our colleague and friend, Dr. Faisal Al-Aufi. He's a consultant radiologist at King Faisal Specialist Hospital. So take it, Dr. Al-Aufi.
Assalamu alaikum, everybody. Bismillah ar-Rahman ar-Rahim. Thank you so much for welcoming me and to have this opportunity to explain imaging and pulmonary hypertension. As you know, imaging is a really important role in pulmonary hypertension, so we would like to go through how we can use these images to help us in diagnosis and get the benefit from the imaging. Today is our workshop, so it's not like to be a theoretical or articles information. So I will go with the groups, the classification, as you know. The group A, pulmonary arterial hypertension, it's including the idiopathic. I'm talking about this groups regarding the imaging related. So as you see here, the first group, it has idiopathic, it has some connective tissue disease, and it has some BVOD and pulmonary veno-occlusive disease and pulmonary capillary hemangiomatosis. Second group is the pulmonary hypertension related to the left heart side, heart disease. The third group is due to lung parenchymal disease. Fourth group is related to the pulmonary obstruction and pulmonary the veno-occlusive disease. And the fifth is unclear, which is the systemic and drug-related. So I'm explaining in this table the strength and the weakness between the modalities. As you know, we can use the chest radiograph, FQ scan, and the CT scan, MRI including, and the pulmonary angiogram as the gold standard for the pulmonary hypertension. So there are just two important points here. As you see, the FQ scan and the pulmonary angiograms, they have the weakness modalities for the anatomical compartments, but the important and the anatomical analysis is the CT angiogram. FQ scan is important for the screening, but for anatomy assessment and the disease itself, the CT angiogram, it has a big role in this. So I would like to take a picture for this one as a checklist. If you have imaging as CT angiogram, so today my case is, my workshop is related to the CT angiogram for the pulmonary hypertension. So as you see here, the pulmonary artery, the first part, we have to check is it enlarged or not. We have a cut line. It's a 29 is normal. I will discuss it later. And we're going to have the ratio pulmonary to the aortic ratio. And if you're going to see, you have to see that if there is any filling defect in the pulmonary artery and any peripheral filling defect as well. So let's go to the second part for the checklist, the right ventricle. So we have to see the right ventricle. Is there any enlargement to the strain, or there is a wall thickness for more than 4 millimeters? Then we go to the septum. If there is any defect, such as ASD, VSD, and the left side deviation for the septal bounds. And we go to the aorta to check. After that, to go to the aorta to check to see if there is any communication between the pulmonary artery and the aorta to exclude any BDA, and to look for any collaterals as a complication of the pulmonary hypertension. We're going to go to the IVC as well to see if there's any dilated, and the contrast goes to the IVC and the hepatic veins. Pulmonary vein to look for any partial anomalies. And the left side, if we're going to see, left heart side, we're going to see any ischemic heart disease, aneurysm, any enlargement of the heart. And we're going to go to the left, to the pericardium, and we see the effusion and the mediastinum for the lymph nodes. So let's talk about the diameter for the pulmonary artery. So we have three, like if we suspect pulmonary hypertension, regardless of the size. It can having any size. And we have the diameter for the pulmonary artery and the ratio for the pulmonary artery and the aorta ratio. So if the population you have low risk, more than 34, it's considered to be abnormal. If the intermediate risk for pulmonary hypertension, it's a 32. High risk above 30. So usually in imaging, you would have to image like that, to measure like that. And if it sees more than 34, we suggest as a pulmonary hypertension. What does it mean for high risk? If the patient have connective tissue disease, Takayasu, or Marfan syndrome. So these cases you consider to be as a high risk, any diameter more than 30 millimeter considered to be enlarged pulmonary artery. As well as the ratio more accurate than the pulmonary artery diameter. As you see, normal population should be 1:1. And the high risk, it's 0.9. More than 0.9 should be suggestive of pulmonary hypertension. And you can see how can we measure the diameter. We measure the pulmonary artery and then we measure the aorta. And we have to look for the RV if it's dilated or not, and the septal if it's bowing or not. And you can appreciate the pleural pericardial effusion. So we know that the pulmonary artery is enlarged. The next step, after we check all the lists we have to look for the parenchyma if he has any parenchymal disease. So for the parenchymal disease, we have, according to the groups, we have findings. So for the first group, as you see, can be normal, can be as a ground glass opacity is distributed, and can be a septal thickening. I will explain these things. Normal, as a normal lung parenchyma, as we see here, we can see just only clear lung, no consolidation, no ground glass opacities. For the group two, we can see edema, ground glass opacity, plus or minus pleural effusion. For a group 3 disease, it's a chronic ILD, it's a chronic diffuse lung disease, such as ILD disease, UIB, NSIB for the pulmonary cardiothoracic. So we are seeing some interstitial lung disease as well. Or can be considered COPD causing this enlargement for the pulmonary artery. The group 4, we can see the mosaic attenuation. It indicates there is some vascular perfusion defects. Goes with the group 4, the chronic thromboembolism disease. And the group 5, it's variable according to the cause itself. If it's drug toxicity, if it's miscellaneous sarcoidosis, it has different causes. So kindly, I would like from you to scan this barcode and see what do you see in the imaging, how to go and approach the case. I just would like to mirror my imaging here for you, the same image you have. Let's go to the display. So that's the first case you have, right? Did you scan and did you check the checklist you have, they ask you before to take an image? So let's go. First, I would like to see the pulmonary artery, right? Let's go together. The pulmonary artery, if it's enlarged or not, yes, it's enlarged, right? And we're gonna go for the RV, dilated, yes, dilated, and the septal is bowing. The wall is thinning. In the meanwhile, you can see the IVC is dilated with a hepatic vein, with a contrast there. And we go to the aorta, and the left-sided heart chambers. No pericardial effusion. And we're going to go through the parenchyma. So for the first image, did you see any abnormality as a workshop? Like let's Let's interpret. Did you see any abnormality here in the CT angiogram? Dilated pulmonary artery. What else? Yeah, there is a mediastinal lymphadenopathy, okay? So let's go to the lung parenchyma. I just want to zoom it for you. Okay. I know it's really fast. As a radiologist, I'm really fast in this. So what do you appreciate here in the lung parenchyma? We can see some interlobular septal thickening, right? And we can see a few centrilobular ground glass nodules. Any diagnosis you have in your mind? Yes. So I heard sarcoidosis first. It can be sarcoidosis here, but we didn't have any smooth interlobular septal thickening. Okay. So in summary, I'm dealing with a lymphadenopathy, interlobular septal thickening, and centrilobular ground glass nodules. It goes with a BVOD case. So we have the first case is a BVOD case. Let's go here. So let's go to the second case. Any abnormality you saw? Sometimes the BVOD and the pulmonary capillary hemangiomatosis is really difficult to diagnose. So that's why I can show you the two different cases. Sometimes really typical, we have a lymphadenopathy, we have interlobular septal thickening. But sometimes you just only have one finding. So this patient is a young patient, and he has a pulmonary hypertension, and the imaging finding, any suggestion, you can mention it. Yeah, I bring this case to show you how difficult some make up the diagnosis. So what I can see here, the centrilobular ground glass nodules is really tiny ground glass, resistant, and with the pulmonary hypertension, you suggest of pulmonary capillary hemangiomatosis. I just want to make a zoom and I will show you how it looks like. You can see these ground glass nodules. Let's go over here. Some ground glass opacities like this one. And like this one. So just only go back to the anatomy. What does it mean secondary lobule ground glass? So as you know, the simple unit for the lung parenchyma is the secondary lobule. You can appreciate the pulmonary vein and the pulmonary artery with the bronchi. So anything filling this space will give you the ground glass nodules. It can be including edema, pus, hemorrhage, blood. So anything occupying this place will give you ground glass. But usually the pulmonary edema and the BVOD, you have centrilobular ground glass nodules affecting that area. with the smooth enlargement of the septal thickening. You can appreciate the pulmonary vein is enlarged and the pulmonary artery, you can appreciate it. So the thickening of the secondary lobular septal thickening, it's over here. It's also include the lymphatic drainage. That explains the images. I will explain it again. You can see the consolidation, it's really like a dense material, but the ground glass is filled with either edema plus or hemorrhage. But the lymphatic drainage over here for the secondary lobule will give you, the yellowish one, will give you the edema itself. That's why you see the imaging septal thickening smoothly, not like the other diseases. And the edema will give you gray zone area or gray opacity would give you the central ground glass opacities. So, and speaking of BVOD, you can appreciate sometimes really difficult, like for these patients are diagnosed by the BVOD/pulmonary capillary hemangiomatous, but clinical history also give you important things. As you see here, after the 6-week initiation of endothelin receptor antagonist, the CT demonstrates ground glass opacities. And you can see the baseline, how it looks like. Sometimes really difficult, but you have to put it in your mind. If you see lymphadenopathy, smooth interlobar septal thickening, and ground glass nodules for the group A. I'm talking about not a common diseases now, I'm talking about regarding each group. So that's the case 3, if you can scan and have a look. Okay, let's see how it. Okay, any finding you appreciate? We can see here, as you see, the ground glass opacity is very bronchoscopy, right? There's not a central ground glass nodules, but there's a patchy ground glass opacities. And you can appreciate here, the pulmonary artery is literally enlarged. So sometimes you have only finding for the lung parenchyma ground glass opacities. So that's suggestive of pulmonary hypertension, as well as that's a pulmonary edema. Okay, let's go to the. And the case 4, you can scan and see. Did you find anything? Okay, dilated pulmonary artery, yes. Okay, dilated IVC and congested pulmonary vein. Hepatic veins. So again, remember our checklist, right? So let's go to the checklist. Pulmonary artery is enlarged. RV is dilated. After the RV, what do we have? I will skip it. I will not kill the case. So the LV, the left ventricle, normal in size. I didn't have the lung window here to appreciate, but we didn't see any lymphadenopathy. I didn't see any pericardial effusion. So we should look for the, and let's see the aorta as well, right? If there is any BDA. No BDA. But I can see, appreciate, like there is a large pulmonary artery, right? But what about this one? We should check for the septum, right? So the ACD between the atriums, and as well there is a partial anomaly retained for the SVC. So let's go back to the anatomy. Probably some people, they are not aware about the anatomy. So that's the 3 branch of the aorta. That's the aorta, that's the SVC. So let's go with the cycle of for the dynamic cycle. So let's go to the SVC. The SVC should be directed to the right atrium, right? But there is some communication here, which is the pulmonary vein drain to the SVC. So the SVC to the right atrium is dilated, and the hepatic vein dilated as well as IVC dilated, go to the RV, which is dilated, hypertubulated, to the pulmonary artery, which is enlarged. Right and left, we checked it. Then we'll go to the pulmonary vein. So the pulmonary vein over here go to the left atrium as normal drainage, as well left upper loop. Let's go to the right. So the right go to the right, the left atrium, and here the middle loop. But where is the right upper loop vein? It's drained to the SVC. So there is a shunting over here, plus the ASD defect. So what we have here, a shunting disease causing the pulmonary hypertension. So we always think about all these things in our mind. What are the causes for the groups? And we look for it. So you can appreciate sometimes the contrast will help you. So some contrast directed to the left atrium, which will give you some shunting over here, ASD, or sometimes partial anomaly. And usually you check the VSD as well. That's what our case we have. That's a venosus defect, the superior part, and that's the right atrium. And you can see the SVC drainage for the pulmonary vein, abnormal drainage. And one of the cases as well, the BDA, a communication between the pulmonary artery and the aorta. Will give you a shunting, and abnormal and dynamic will increase the pulmonary hypertension. So what you see here, left atrium enlargement, mitral calcification, it means mitral disease he has. And we appreciate interlobar septal thickening, effusion, some coronary artery disease, pericardial effusion, and this patient, if you see dilated left ventricle, and the patient have pulmonary enlargement, and that's the group for the left heart side, as well as ischemic cardiomyopathy causing right heart pulmonary hypertension. There's 2 examples for the scleroderma and pulmonary hypertension. You can appreciate the lung parenchyma changes, ground glass opacity, reticulation, fibrotic changes in the lower loops. That goes with the NSIB pattern. And we can appreciate the dilated esophagus is one of the commonest findings we can appreciate in the scleroderma. What I appreciate here, you can appreciate the increased lucency of the lung parenchyma. I'm not sure if it's clear for you here, but in my screen here, you can appreciate the central lobar lucency indicates emphysema. That's one of the causes of the pulmonary hypertension for the group of the pulmonary disease. 3 examples. At the upper images, you can appreciate the nodularity, upper and lower loops, some fibrotic changes. That goes with the sarcoidosis. The patient has sarcoidosis. And in the lower loop, you can appreciate scattered nodules, and the patient is a smoker and a young male patient. And that was a pulmonary Langerhans histiocytosis. These as lung parenchymal findings will give you a cause for the pulmonary hypertension. So you can scan the last, I think, yeah, one of the cases here as well. I will give you like a few minutes to appreciate the findings and we can discuss. So usually in imaging, we always say to our trainee as well, go approach. And if you go approach, you will not forget about what you have to, like what you have to go approach to see what are the things you should go through and exclude. So any abnormality you can appreciate. So first of all, we have pulmonary signs of pulmonary hypertension, right? We have enlargement of the pulmonary artery, RV are dilated, and the septum is shifting. IVZ is dilated to the hepatic vein, and contrast reflex to the hepatic vein. It means there is no pressure to go to the left heart. So what we left with the groups, we have the fourth group, right? So let's see the pulmonary artery. So I'm not sure if you can play with the window over here, yes. So the right pulmonary artery, upper loop, is good, but there is some tortuosity and we have some I just want to show you tortuosity and some linear filling defect and the eccentric filling defect over here. And we can go to the right lower loop. We can appreciate the vessels are attenuated. We didn't expect these vessels to be like this size and irregular appearance with some eccentric filling defect, right? That's the first, that's in the other, in the right lung. If you go to the left lung, I highly recommend to go every artery and to see where's the filling defect. Sometimes you just only appreciate one filling defect. But the signs are it's variable. It should be either distal to the proximal, and you can appreciate the eccentric filling defect, narrowing of the pulmonary artery, and tortuosity as well of the left lower lobe. You can see the filling defect of the segmental bronchi and the occlusion over here. So in this case, we are dealing with a CTIF case, chronic thromboembolism pulmonary hypertension. The sixth case, we can go through it. Any finding you appreciate? So let's go together with this case. Let's say the pulmonary artery is enlarged, right, compared to either aorta. The right ventricle enlarged, the right atrium enlarged, IVC dilated, and the contrast you can appreciate it to the hepatic vein. Ignore the hepatic cyst. It's something we care about to mention. And let's go to the pulmonary artery. After we exclude any septum shunting and the ASD and the partial anomalies. So let's go for my approach. I usually start from the right upper lobe, right lower lobe, left upper lobe, and left lower lobe. So let's go here. You can appreciate tortuosity and some hypodensity, web-like appearance, which we call it like a small linear filling defect. Then we're going to go to the right middle lobe as well. You can appreciate this linear filling defect. I'm not sure if you can clearly see it. And then the right lower lobe central filling defect, web-like, linear. Again, that's the case of, you can appreciate over here in the left lower lobe. In imaging here, we should, as you know, we should evaluate the disease proximity because of the treatment of the surgical planning and angioplasty. For imaging, if you just define this, the filling defect are proximal, which is like segmental, and the lobar, above the lobar and the main, it will go as a classification of San Diego. You can use it, and you can classify these lesions, and you can then depend on your management. And you can see here the left upper lobe. Usually the CTF cases, it's bilateral and sometimes really thin or linear defect, which is difficult to appreciate, but you have to think about it and know the understanding of the disease, how it goes and how it's resolved from the acute to chronic. So again, let's go and review some typical findings of the CTF. You can appreciate the central filling defect here, the eccentric filling defect, the hypodensity, attenuation of the vessels, again attenuation in the suspected pulmonary arteries, which should be enlarged. As well, sometimes you can appreciate just only a hypodensity within the wall. People, they mix it with a lymph node or another wall of the mediastinum, and the bronchial artery dilatation, and you can appreciate the filling defect in the right lower lobe. The pulmonary arteries here in the right lower lobe is like patent, you can see the contrast go through, but there is a diffuse, diminished perfusion here. The contrast, you can see the vessels, there is no vessels going to the right. So the question usually in the practice, is it acute on the top of chronic or a chronic BEs? How can we differentiate? So usually the acute is the central filling defect give you the sign of Polo sign, is a central hypodense, usually with enlargement of the vessels, but the chronic will give you partially filling defect, linear web-like appearance and attenuation. Lung findings usually with the chronic pulmonary embolism will give you a mosaic attenuation, or what you call it like a perfusion defects, but for the acute pulmonary embolism will give you infarction. Some hint for the pulmonary, if you see this, some people they call it, oh, that's acute pulmonary embolism, go and risk the patient, but you can appreciate here the calcification, which indicate the chronicity of the disease. And you can appreciate here the mosaic attenuation, like what I mean, the difference between the lucent lung and the perfused lung. So what's the abnormal? The abnormal is the lucent lung. There is no contrast go to that normal parenchymal lung. And you can appreciate here in the subiodine subtraction, you can see the filling defect and the decreased perfusion due to that's one of the images called dual energy. We abstract the iodine from the non-iodine study, and we can see the defects. I just want to show you how comparable to the pulmonary angiogram. Sometimes now it's equal for the assessment of the disease. You can appreciate the irregularity over here, which is, we can appreciate it over here, some irregularity of the right main, and some filling defect as well in the right lower lobe. So again, explaining these findings, how it looks in the lumen, eccentric. Sometimes people, they think it's a soft tissue thickening. No, it's the hypodensities filling defect. Linear, we can appreciate it over here. The linear filling defect in pulmonary angiogram, it's a linear filling defect with web-like appearance. And irregularity of the vessels indicates synchronicity as well and decreased perfusion. But the problem is many pitfalls can fool you to call it as a chronic embolism, such as lymph nodes. So you have to know about the lymph nodes, where is the location. People, they are mixing between interlobular lymph nodes and chronic embolism. So I was appreciated here, there is a lymph node as well here, the lymph node and interlobular lymph node. How can I differentiate? Usually in my practice, I have to follow the vessels and I see if there is any change in the caliber. Should be in the pulmonary artery tapered, not like a tapered and a enlargement in size and go back. And usually these lymph nodes, usually it happens at the bifurcation and between the pulmonary vein and pulmonary artery. And the most common artifact, pitfall we have is the motion artifact. Patient not cooperative, patient sick. So usually I like to do the imaging for the patient who's really like for assessing the disease, especially patients with a chronic thromboembolism disease. Usually they are like they are sick, but they came as an outpatient. It's not sick like as acute pulmonary embolism, short spread tachycardia. Yes, it has short breath, but sometimes it's really, they can't control the breathing. But I usually ask the physician to take the good time to scan this patient, and I have a different protocol for these patients, which is, I usually say it, for the technologist, I don't know if there's any radiologist here, I'd like to image the CT with a delayed contrast injection. What I mean, this is not like normal angiogram for any acute pulmonary embolism, because if the pressure is high for the pulmonary artery and the lung parenchyma is reduced, and if the patient have a PVOD or any disease that prevent or has a high resistance of the blood pressure, will give you a false positive and a slow flow, and you can call it as a filling defect. Sometimes you can use as I explained, iodine mapping, the subtraction dual energy. You can appreciate the filling defect, the distal filling defect you can appreciate, although we didn't have anything in the lober, but we see some middle loop, lower loop, and anterior loop. Although we have a normal distribution or a normal mosaic attenuation and filling defect, but not that extending more than 3 loops that when they mention in the literature review. The important thing as well, I recently see this, some like recently describe it, the complication for the pulmonary hypertension. We can appreciate it through the pulmonary, from the CT as a compression for the coronary arteries. If we have enlargement of the pulmonary artery, so we have to take care and we see how it's compressed to the coronary artery disease. Some practical consideration for the CT angiogram if you talk to your radiologist or a technologist. So usually it's not gated, so you don't have to gate this image. It's just only thin slices, 1 millimeter. That's what I like. It's nothing like, some institute, they put it as a 3 millimeter, 2.5. No, we didn't prefer that. As we know, the protocol for the CT angiogram is a slow flow and, a flow of gating of 20 and the flow of 4, and the slice thickness is 4 millimeter. Usually we are taking from the abdomen to the chest to exclude any filling defect in the abdomen, in the lower cuts, which is really common to have that place. And we are using pulmonary artery tracking. That's just only a radiological information. Tracking that, we put the track on the pulmonary artery, and once it's enhanced, we image that one. So we put area of interest For the angiogram, probably the technologist will ask you, or the physician, what you would like to see. Yeah, I would like to see the pulmonary artery. So you put the ROI, the area of interest, at that place. What's enhanced your image directly. For me, what I usually like, and they give the message, for the CTIF patient, I like to image the patient a little bit delayed, not like normal patient, because it will make a big difference. Sometimes they overcall the slow flow for the pulmonary artery, especially for the distal, especially if we have a high resistant pulmonary artery, they overcall it as a pulmonary hypertension and progressing of the disease. So I usually say no, take it delayed, or I put it in the request, I ask them to put it in the request, modified protocol for the CT pulmonary angiogram, and explain the physician, this patient have a chronic pulmonary embolism, I would like to see the distal artery disease, and can we make it a little bit delayed or modification for this lesion. Thank you so much. And that's the suggested articles. I really appreciate your scanning and participating in the cases. And welcome to Riyadh for the one who came outside and enjoy the weather. And I wish I can give you some hints to use the CT angiogram for helping the patient and diagnose the patient. And if you have any question of any inquiries for the imaging, I'm really welcoming, and I will be glad to answer all these questions. Thank you.
Thank you very much, Dr. Faisal Al-Aufi, for an excellent interactive workshop. Next, I am delighted to introduce Dr. Abdullah Al-Khadir. He is an interventional cardiologist at King Fahd Medical City and PH. He is also the head of adult cardiology at King Fahd Medical City. He has yet another excellent interactive workshops. He will explain to you what is required from you. Thank you very much.
Shukran Abu Saleh. Just a correction, I'm not the head of the cardiology department, and I don't want to be. I don't want to be the head, I'm the program director. Assalamu alaikum wa rahmatullahi jami'an. Good afternoon, everyone. Welcome to this workshop. And it will be an interactive one. So if you open the book that was given to you at the time of registration to page 17, you'll see your homework, which we're going to do together at the end of this workshop. But before we do the homework, let's start with some basics and some stories. So you can ignore that for now, because we're going to come back to it at the end of this. Okay. So history of right heart catheter, or catheterization in general. So back in 1929, Dr. Werner Forsman, he tried doing advancing catheters into the human bodies in cadavers. And then he was intrigued by the idea, so he decided to test it in a human being. So he asked one of his colleagues to place a small IV cannula in his antecubital vein, and then he asked the colleague to push that urethral catheter all the way in. So his friend started doing that until he passed to 35 centimeters, and then he got worried. He was afraid that he's going to damage something, so he abandoned it. So of course, Dr. Forsman was not happy with that, and he said, okay, you go away, I'll do it myself. So the next day, or the next week, he placed the cubital vein himself, and he was downstairs in the procedure room. He applied local anesthetics, and then he pushed this catheter himself all the way to the end. And then while the catheter in place, he ran upstairs to where the radiology department was, and he took an X-ray of that urethral catheter, and you can see it here. You see the tip of it in the right atrium. And he was able to see that picture, as you can see here, by means of a mirror held for me by the sister meaning the nurse. So that was the first catheterization ever. So they were very progressive back then. They were doing it from antecubital veins, which is something we do nowadays routinely. Okay, so when we do right heart catheterization, a lot of people say, I'm an interventional cardiologist, and a lot of my colleagues, they say, okay, we have a right heart cath, let's just get it done with very quickly. It will not take long. And they just do it very quickly without paying attention to the details. And that's where you get into trouble, because a right heart catheterization that is not done properly will probably give you more questions than answers. So it is technically demanding procedure. It requires meticulous attention to detail to obtain clinically useful information. In general, if we're doing right heart catheterization for pulmonary hypertension patient, it is usually a procedure that we like to do as the last part of the workup, after all of the imaging, laboratory, and clinical work has been finished. So the patient should be in a stable position in a non-acute clinical condition for the differential diagnosis of pulmonary hypertension. So the fluid volume should be optimized as much as possible. We should avoid sedation as much as possible. There are some few points to consider. Any patient who comes into the lab, you should make sure they don't have left bundle branch block. The reason is, if you go in with your Swan Gans or pulmonary catheter, and you knock off the right bundle, guess what's going to happen? You'll end up with complete heart block, because the left is gone, and now the right bundle is also gone. So be careful of that. It is not a contraindication, but you have to be careful when you see a left bundle, and should probably alert your cath lab team to get a transvenous pacemaker ready, just in case. If there is a recent pacemaker, you should also be worried and careful, because sometimes maneuvering the right heart catheterization, you can dislodge this newly implanted pacemaker. You should inspect all of your pressure tubes. They should be as short as possible and as tight as possible, free of air, free of kinks, and free of clots, and full of normal saline to get the proper pressure measurement. And in general, we like to have the ability to print the ECG and pressure tracings. I see a lot of right heart cath numbers that have no pressure tracings, and sometimes you have to be a little bit paranoid about others' interpretation of the pressures, and you have to confirm it by seeing it yourself. So always try to obtain pressure tracing if possible. There are not a lot of contraindications, but if you have right-sided endocarditis, you don't want to push that vegetation in the tricuspid valve or pulmonic valve into the pulmonary circulation. Same thing if there was a mass or thrombus. And you don't want to go through a mechanical right-sided valve if there was any. It's very rare for the surgeons to place mechanical valve in the right-sided chambers anyways. Okay. So there's this concept of leveling and zeroing. So basically what that means is you want to establish where is your 0 point, because in the right heart catheterization, the most important pressure that we're interested in is the left atrial pressure, or the wedge pressure. So we want to locate where is that left atrium level in a patient who's lying supine, and we want to place our transducers at that level. So that's what's meant by leveling. So there are multiple ways of trying to establish the leveling point, and based on a CT scan of multiple patients, we were able to say that roughly, if we're going to choose one point that fits for everyone, it will be the mid-thoracic level, and that point will correspond to where the left atrium is. So what we do is, in the cath lab, we have this transducer here, and there is a line that says, locate at mid-heart level. So we locate that line exactly where we measure with the ruler where is the mid-thoracic level, and then we place this line at that level. So that's what's called leveling. Okay. If this is not done properly and the transducer is up 5 or lower 5 centimeters than where it should be, you're going to have a significant difference in the numbers. And the wedge pressure could change the patient from someone who can respond to medication into someone that will say, oh, he's probably post-capillary, will not benefit from medication. So this can make a huge difference. Okay. What catheters do we use? We have something called a Swan-Ganz catheter, the one in the left. So basically it has multiple ports. We have one port for the distal port, and then we have the blue one, the proximal port. We use that one for thermodilution, cardiac output. And then we have a balloon, and the purpose of the balloon is when we inflate it, it will help the catheter to float going up, and it will be less traumatic to the heart when we are advancing the catheter. This is a cross-sectional in the middle here of the catheter. So you see the proximal port, the distal, and then this is for thermodilution, and this is the air for the balloon. Swan-Ganz, those are Swan-Ganz. The two people that in 1970s came up with this catheter, and they won the Nobel Prize for that. Okay, so what are the possible accesses that we can use? And we know all roads lead to Rome, so any vein will lead to the right side of the heart if you can get through it. Traditionally, people have done it through the internal jugular vein, femoral vein. This can be sometimes challenging, especially if there is a huge right ventricle. And more recently, we started doing this through the brachial vein. And why through brachial? Because there's way much less, or way significant reduction in the access site complications. You can establish hemostasis immediately after the procedure. You just ask the patient to place a finger on that puncture site. They can ambulate immediately. And one of the possible complications is if you, by mistake, hit the brachial artery instead of the brachial vein, or you hit the brachial nerve. But that's very rare. So what we do is we ask our nurses to... so this is the anatomy of the brachial vein. And you can see we have two major brachial veins here that go and join the SVC. So we have the cephalic and the basilic vein. Sorry, the basilic is the more medial and the cephalic the more lateral. So you want to have an IV around this area, and you want to go through the most medial vein. Why? Because when you advance your catheter through this area here, you might have some resistance if it's going through the cephalic. So it's much better and easier for the catheter to go through the basilic vein. Okay, so what we do is we ask the nurses to place a small cannula, and you can see the cannula pointing toward the medial side of the patient. So they can place it anywhere in the recovery area. And then in the cath lab, we go and clean the area with chlorhexidine and exchange that with a regular sheath that we use for radial access. 6 French sheath would be enough. So very simple to do that. So you just put a wire through this hole, you put the wire all the way up here, you take this syringe or the needle out, and then you place your sheath in. Okay. When you establish the access, you then you put your Swan-Ganz in, and sometimes you need to put a wire ahead of it just to facilitate its passage. Sometimes you have resistance of the catheter going in, so you can maybe change the position of the arm or ask the patient to take a deep breath, or sometimes nitro can help a little bit. Sometimes deflating the balloon, re-inflating the balloon will help you go through that vein. And if you can't push further, you can inject contrast, so it will help you navigate through. If all of this doesn't work, then of course we have other veins to go through, either jugular or femoral veins. Okay, now here is the interesting stuff. So now we established access, we pushed our catheter all the way to the SVC, or right atrium, and now it's the time for obtaining the information we want to. So in general, there are 4 pressures that we are interested in. The first one is the RA, and in the RA, we want the mean RA pressure. Then we push further, and we have the RV. In the RV, we are interested in the systolic, diastolic, and end-diastolic pressures. And then we push further, and we have the PA, and in the PA, we're interested in the systolic, diastolic, and the mean PA. And then finally, we have the wedge pressure. In general, we like to measure pressures at end expiration, because that's where the extrathoracic pressures are more mostly equalized. Some patients, they have significant respiratory swings, and in those patients, you can average the pressures over the whole respiratory cycle. Okay. So in this example here, so we have on this diagram, we have the right heart cath. So we took an RA pressure, and it's between 0 and 8. That's the normal values. Then we pushed. We have an RV, and that's how the RV waveform looked like. And you can differentiate that from this waveform, because in diastole, look at what happens in diastole in the RV. The RV gets filled in diastole, so the pressure goes up. Look what happens in diastole and the PA. In diastole, PA is relaxing, and the pressure goes down. So that's one way to differentiate. Also here, not maybe depicted here, we have a diacrotic notch, which is not present in here. And then we push further until we get to the wedge position. Now, the wedge concept is interesting because what we mean by wedge is we want the balloon, so this is the tip of the catheter, and when the catheter is in the PA, it's going to measure the PA pressure. But imagine what's going to happen when this catheter is pushed, and this balloon now is obstructing blood flow from this. So the only thing that this catheter is seeing is the column of blood that is hooked all the way to the pulmonary veins, then to the left atrium. So when we get into the wedge position, the pressure that we are seeing is actually the left atrial pressure. It's no longer the pulmonary artery pressure. So this is what's meant by wedge pressure, as when you have the balloon wedged in a small pulmonary artery branch, and the pressure now is reflecting the left atrial pressure. Okay. So in the guidelines, they give you a number of measured variables that you need to do at right heart catheterization procedures, and then there are calculated parameters that also have to be done. So let's go over them one by one, and this is a good preparation for the homework that we're going to do together at the end of this talk. So right atrial pressure, normal is 2 to 6. Some people say 8. Pulmonary artery systolic pressure is 15 to 30. Diastolic is 4 to 12. And mean of 8 to 20. And I want you to memorize this number. 20 is the cutoff or the upper limit of the normal mean PA pressure. Pulmonary artery wedge pressure is less than 15. Remember that your pulmonary artery wedge pressure cannot be higher than your diastolic PA pressure because the blood is moving from the lungs to the left atrium. So there are only one case one condition where you have severe MR where the wedge can be higher than, the wedge can be higher than the diastolic. But in general, your pulmonary artery diastolic pressure should be slightly higher than your wedge. Then cardiac output, 4 to 8 liters per minute. Your mixed venous saturation is 65 to 80. Then you calculate PVR, and the upper limit here is 2 Woods unit, or if you want to convert it to dynes, then you multiply by 80. Then things like pulmonary artery, total pulmonary resistance, cardiac index, stroke volume, pulmonary artery compliance. These are like additional parameters. Okay, so let's go to examples. So when you see something like this, try to approach it with, first of all, look at the ECG tracing on the top. And you can see we have a normal sinus rhythm. Then you look at the scale. And here we have a scale from 0 to 50. Ignore the scale in the middle here. It's not accurate. So we have the scale, a pressure scale of 0 to 50. And then we have some wiggle lines. And because this is the first pressure that you see, most likely this would be right atrial pressure. In the right atrial pressure, we're interested in the mean pressure. So the mean pressure would be here. This is number 10. So the mean would be around 11. Okay. Next, we push the catheter further, and we have some change in the shape of the waveforms. So we also changed the scale. Notice now it's no longer 0 to 50, it's 0 to 100. So what is this? Is it pulmonary artery or RV? And the reason is we look at the diastole. In the diastole, the RV gets filled and the pressure goes up. So what is the RV systolic pressure? Anyone? 95? Yeah, that's reasonable, like 96. End expiration would be around here, so 95 is reasonable. So the question now, based on the information that we've had so far, true or false? This patient has pulmonary hypertension. Raise your hand if your answer is true. False? I don't know. I would vote for I don't know. Any reason why? Huh? We need to see the pulmonary artery pressure because we have not ruled out the pulmonic stenosis. So this could be pulmonary stenosis. And we've had cases where you're missed by that. So we have to go through the pulmonary valve and make sure the pulmonary artery is the same as the RV pressure. So let's go to the pulmonic valve. And now you can see the difference in the waveform. So one thing is, look at the diastole. The PA, the pulmonary artery, relaxes during diastole, so the pressure goes down. So we have systolic of 93, which is similar to the RV systolic pressure. So this is not pulmonic stenosis. So now let's do the same question again. This is pulmonary hypertension. True or false? It has to be true. There's nothing else. Okay. We have the diastolic of around 33, and then we said the mean PA pressure, the definition is the mean PA pressure more than 20. So what is the mean PA pressure here? We'll look at the scale. This is 50, this is 60, so it has to be around 53, 54. Severe pulmonary hypertension. Okay. Is this pulmonary artery hypertension? Yes? No? We don't know. Huh? Yes? We need to see? Distal. What do you mean by pulmonary artery branches? So we need to see the wedge pressure. If the wedge is less than what? It will be PAH. 15. We call it pre-capillary pulmonary hypertension. Right, let's go and push further while the balloon is still inflated. And there you go. So now this is, we can see clearly that the waveform has changed and the scale has changed, which we asked the technician to change the scale so we can look at this more carefully. So the scale now is 0 to 20, and we said we're going to take it at end expiration, so it is around here, 14. So 14 is less than 15, so theoretically speaking, this is pre-capillary pulmonary hypertension. Okay. For completeness, we went and did this thing. What is that? And why did we do it? So look at the scale, 0 to 200, and we have a waveform. We're going to discuss if this is ventricular or arterial. And we have a systolic pressure of 120. Remember, the RV systolic pressure was 90. So this is higher. So where is that? Huh? Left ventricle. Why did we do left ventricle here? To see, because, listen, when we say pre-capillary, post-capillary, what is the pressure that we're interested in is the left atrial pressure. There are three ways to measure the left atrial pressure. One is the wedge pressure that we discussed before. Remember, the LV and the LA at the end of diastole, they have the same pressure when the mitral valve is open, because they basically LV EDP, left ventricular end diastolic pressure, and left atrial pressure, they should be the same in the absence of mitral stenosis. So in this particular case, we went to the left system to double check that the wedge that we got was actually a true wedge. And you can see here, it's around 14, 15. So still within the limits for the wedge pressure. Usually it's lower than this, but we'll accept this as pre-capillary pulmonary hypertension. Okay. Some pitfalls when we do right heart catheterization. So we have something called dampened waveform. When the this is a normal waveform. When it gets like that, you lose the contour of the waveform. It's called overdamped, and sometimes it's underdamped when there is too much ringing in the catheter. So you have to be familiar with that. This is what we discussed before. So 3 ways of measuring left ventricular filling pressure. You either do wedge pressure or LVEDP, or if you're lucky enough and you have an ASD or PFO, you can just go directly to the left atrium and measure the pressure there. How do we confirm wedge position when we're doing it under fluoro? So you will see a change in the waveform. It will be different from a PA into a wedge waveform like we saw. You can aspirate some blood, and the blood that you aspirate from which position will be from where? Let's repeat the question again. So you are in a wedge position, and then the balloon is occlusive, and now you're aspirating blood from that catheter. Where is that blood coming from? Left atrium, pulmonary vein, left atrium. So the saturation will be 99, 100, okay? If you deflate the balloon and then you aspirate blood, where is that blood coming from? From the pulmonary artery. What is the usual saturation in the pulmonary artery? 70, 65, okay? Okay. The most important pressure to measure here, as you can see, is the wedge pressure. Why that is? Because it's going to tell us this is pre-capillary or post-capillary. And why that distinction is important? Because it's probably the most important pressure that we base our treatment decisions on. If the wedge pressure is 20, it is unlikely that we're going to give this patient medication. If the pressure is less than 15, then we call it pre-capillary and we might consider giving medication. So to determine wedge pressure carefully, to be honest, this is not real life. Real life, you rarely see this, and we saw that in the example that I showed. But theoretically, you locate where the A wave is. So each wave here, we have A wave, we have a V wave. Those are the wedge waveforms. So the A wave, V wave, A, V. And the A should occur like just after the QRS. The V should occur just after the T wave. Now, to measure or to establish what's the wedge pressure, you take the top of the A, the bottom of the A, you combine them, divide by 2, and you get your wedge. So in this particular case, it is 11. Okay. If you depend on the machine, it can fool you, because the machine doesn't do that. It looks into everything and combine it together and then take the average. In this example here, we have what's called a large V wave. We see that sometimes in patients with severe MR. So the machine said, I'll take the average of all of these lines and gave us this blue line here as the wedge pressure. But in fact, that's not the true wedge pressure. Why? Because this is our A wave, and the actual wedge is the top of this, the bottom of this, and halfway through. So that's the true wedge. But in this particular example, the machine, the computer, overestimated the wedge and probably prevented this patient from being labeled as pre-capillary. So be aware of that. This is an example of someone who has large respiratory swings. They have either large body mass or severe COPD, and whenever they take breaths in or breaths out, their pressure changes dramatically. So in those cases, you want to really take the pressure at the end expiration. What is fluid challenge? Fluid challenge is something that we do when we do not believe the numbers that we've received. So I'll give you an example. We have someone who is 6-year-old, diabetic, hypertensive, obese lady with atrial fibrillation. And she's been referred because of echocardiogram that showed pulmonary hypertension. So we wanted to do right heart cath to see what's going on with this pH. Then we go and do that. She's been on Lasix for a few months, and to our surprise, her wedge pressure was 12. Do you believe that wedge pressure? No. Why? Because everything else is telling you this is post-capillary. her age, her body mass index, her hypertension, diabetes, all risk factors, HFpEF, etc. So we do not believe that. So how do we confirm that this is pre-capillary or post-capillary? We challenge that number. So I'll show you an example here. This is a patient that we just discussed, and her wedge was 12, but we did not believe it. So we said, let's challenge it, and we'll give her additional volume. A normal person would be able to tolerate 500 cc without any change in their wedge pressure. Someone with HFpEF or post-capillary pulmonary hypertension, they do not have that same ability to tolerate. So when we give the fluid challenge, her wedge pressure jumped to 22. And now we can safely say, oh, this is post-capillary, clearly, no question about that. So this is the indication for fluid challenge. Do we do it for everyone with low wedge? No. We do it for those patients who have low wedge, and based on their clinical characteristics, we do not believe that they should have low wedge. Do we do it for those patients who have high wedge? No, because we already have the answer. You don't need to prove it. It's already there. Okay. Sometimes what happens is something called over-wedging. So we see what happens here is the tip of the catheter gets is basically touching the wall, and what you end up seeing is lines that are like this. So this is not wedge pressure, it's just over. So you have to change the, deflate the balloon, then inflate again in a main PA, and go again, and you'll probably have a better waveform. Okay. Underwedging basically is the opposite. So you have incomplete occlusion of a small PA branch, and basically you're not completely wedged, so you see a false elevation of the wedge pressure. Be careful, this is not a procedure without complications. So because we deflate, inflate, deflate, inflate, if you do that in a small branch and you do it very quickly, you can basically, if you're deep enough, rupture the very compliant pulmonary artery branch. So if you have to deflate, inflate, then please do that in the main PA, so you reduce the chance of this catastrophic complication. After we obtain all the pressures, we want to do shunt assessment to make sure there are no left to right shunts, ASD, VSD, etc. So we take samples from PA, RA, IVC, SVC. There is this concept of step up. So if the, let's say, RA saturation is 70, then you go and measure the PA saturation and it's 80, you know there is a left to right shunt from somewhere between the RA and the PA. It has to be a VSD. So that's the concept of step up. The saturations, they should be within close proximity of each other. Cardiac output is another thing that we have to do. So there are two methods of doing cardiac output. Why do we do it? We do it because it's prognostic. So if I tell you this patient has a cardiac index of 2, everything else is similar, it's probably have worse prognosis than someone with a cardiac index of 3. We also use it for PVR calculation. You cannot do PVR without knowing the cardiac output. So the gold standard is something called direct FEC, but this is rarely done in clinical practice because it requires like a mask that clearly measures the expiratory gases and inspiratory gases. We don't have that. We don't have the time to do it. So we use something instead. We use something called either an indirect FEC or thermodilution. Thermodilution is probably more accurate, except in patients with shunts. And basically, you inject some saline in the RA, and the sensor at the distal end of the catheter will measure the temperature change, and then through a complex computerized calculations, you get a number, and that number is your cardiac output. So basically, here is an example. Just explain it here for a second. So we have two examples here of, just focus on the red and blue. Now, we inject here in the RA through the proximal port, and then the pressure sensor is, the thermistor is here. So if we inject a known amount of a fluid with a certain temperature, this thermistor is going to see that change in temperature over time. If it sees it like this, that's a normal cardiac output. But if it takes a long time for the temperature to change, peak, and then come back to normal, we know that the heart is not pumping vigorously. So that's the difference between the two examples. A normal cardiac output, a cardiac output that takes a long time to change the temperature and then bring it back to normal. Okay. Indirect FIC is another method. It requires a lot of variables to be entered, and that what makes it makes it less accurate because there are lots of sources of errors. But basically, this is the basic equation. And then once we establish the cardiac output, we go and measure or calculate cardiac index, PVR, TPG, DPG, and I would recommend you that you take note of these equations because we're going to use it here in a few minutes. Okay. So, probably give you a couple of minutes of break to just take a deep breath before we do the exam. So, as again, on page 16 in your booklet, or I think we have the sheets have been distributed. We're going to go through examples. And this time, I want you to imagine the numbers that we're going to have in those patients. Okay? And then we'll do them together. Okay. So we have 3 examples. We'll start with the first one. We have a 30-year-old female. She was labeled as severe idiopathic pulmonary arterial hypertension. She has NYHA class 3. Her JVP is raised. So please look at the sheet that you have, and we've asked you to expect what are the right heart catheterization numbers. We'll give you a minute or two just to go through the numbers. In your mind, based on this limited information, please write down what are the expected numbers that we're going to see if we have to do a right heart catheterization today on her. And please do not write high or low, just write a specific, commit yourself to a specific number. One more minute. Of 1 more minute. It seems people are still working. So I'll tell you, if you get these answers right, then you can go and do right heart catheterization yourself. You pass the exam. This is all you need to know. Yeah. Let's see, raise of hands if you've finished. So we still have people working? Okay. Take your time. We have lots of time. Okay, let's do this together. So, what do we think her mean RA pressure is going to be? Anyone with a specific number? More than 15? More than 15, okay. Anybody else? Anyone thinks her RA pressure is going to be less than 8? Okay, we have few. Why do you say you think it's less than 8? What makes you think it's less than 8? Use the mic, please. So we want this to be interactive. And again, I mean, there are, the discussion is probably the most important thing here. Is we want to just walk you through the process and correct any. So, yeah. So, again, remember, we have the normal variables here. The RA pressure should be between 2 and 6. So I'm giving you an example of a lady who has NYHA class 3. She barely is able to walk, and her JVP is raised. So JVP is a good reflection of your RA pressure. So if the JVP is raised, her RA pressure cannot be normal. So if you say anything above 8, your answer will be accurate. If you say above 15, I would buy that because, yeah, this could be above 15. Okay, what do you think her PA systolic pressure is going to be? Come, high? 40 systolic pressure? Remember, the normal systolic is 15 to 30. 70? Sure. Sure, let's agree on 70. طيب, okay. What is her PA diastolic pressure then? 30? Does it make sense to everyone? 30 diastolic pressure? I think it's, yeah, we have the normal here. So the diastolic pressure is 4 to 12. So 30 would be normal. Right. What is her mean PA pressure? If we said her systolic is 70, diastolic is 30, what is her mean PA pressure? How do we know that? Huh? How do we calculate mean pressure based on systolic and diastolic numbers? We all talk about MAP. Keep the MAP above 80. Keep the MAP above 60. What is MAP? Mean arterial pressure. What is it? How do we reach that number? Yes, so it is 1/3 of the systolic pressure plus 2/3 of the diastolic. So let's do the equation here. 2/3 of 30, the diastolic pressure would be 20. We said diastolic pressure is 30, صح? So 2/3 of 30 would be 20. And what is the systolic pressure? 70. So we'll take 1/3 of that. So that's, someone help me out here. I'm on the spot. 23 plus 20, 43. So the mean PA pressure is 43. Everyone agrees? Okay. What is her expected wedge pressure? Normal is not an answer. We want a specific number. Less than 15 again is, commit yourself to a number because we're going to use that for the PVR calculation. 13? Sure. She's 33. Her wedge will be very low. So let's say 10 to make it easy for calculation. Okay. What do we think her PA saturation going to be? 60? 70? She is struggling to breathe. She cannot walk. Yeah, I would say around like late 50s, early 60s. Okay. What is her cardiac output, expected cardiac output, if we have to do thermodilution on her? Throw a number. Less than 4 could be 1 and could be 3.9. 3.5. Now, let's say 3.5, okay? What is her PVR based on the information we've given you so far? We have the equation here for you. Mean PA was 43, wedge was 10, 9.4 Woods unit. So that's a high PVR. Okay, so this is the case number 1. Any questions? We're all good? Okay, let's move on to case number 2. So we have a 25-year-old female with scleroderma. She's very active and has no symptoms. Screening echo showed normal RBSB of 30. With normal RV with RBSB of 30. So let's spend some time here again going through the numbers. So 2 minutes. This should be easier. Okay, so what do we think her mean RA pressure is? 5 is reasonable. I would buy that. What do we think her PA systolic pressure is? 20, 40, 30. For the people who said 30, why did you say 30? Huh? Okay. Any other hints why you picked 30? Because the echo told us 30. So if you have to guess, you probably guess with what the echo said. They're not always agreeable, but out of the 3 numbers we've given you, 30 would be the most reasonable answer. Okay. PA diastolic? 4? Yeah, anything between 4 and 12 would be accurate. Let's say 10, just because we want to. What is the mean PA pressure if her systolic is 30 and her diastolic is 10? Remember the equation. 2/3 of diastolic, that's 2/3 of 10, so that's probably 7. And 1/3 of 30, that would probably 10. So this patient mean PA pressure would be 17. That's a normal mean PA pressure. Moving on, what's her wedge pressure? 8, 10. Let's say 10 so we can, okay. What's her expected PA saturation? 70, I would buy that. What is her expected cardiac output? 5, let's say 5. She's asymptomatic and she's quite healthy. So what is her PVR then? So we have mean PA, we said it is 17, and we said wedge of 10. We said cardiac output of 5. So 17 minus 10 divided by 5 would be around 1 point something. So that's a normal PVR. 1.4. So that's a normal PVR. Okay? All right, let's go to case number 3. We have 70-year-old male with diabetes, hypertension, coronary artery disease. He has NYHA class 3 symptoms this time, and he has bilateral leg edema. His echo showed LVH, normal LVEF, severely enlarged left atrium, and the RVSB was estimated at 60 millimeter mercury. 2 minutes to go over the numbers. Again, for the newcomer, you find the sheet in page number 16 in your booklet. Let's do this. So what do we think the mean RA pressure in this case is? Cam? 12. Any other takers? Yeah, he has severe leg edema, so his RA pressure has to be severely elevated. So yeah, let's say 15, okay? What do we think his PA systolic pressure is? 60, because the echo said 60, so we expect them to be close to each other. Okay, so 60. Diastolic PA pressure? 30. Okay, let's say 30. What is the mean PA pressure then? So 2/3 of 30, so that's 20, and 1/3 of 60. So PA pressure, mean PA pressure is 40. Okay, what's the wedge pressure? Oh, 30, if we said 30, he would be probably close to about to be intubated. So 20, 25, let's say 22, just for simplicity, okay. So PA saturation? No, 30 again, he will be in cardiogenic shock. So it will be around like, again, 50s, 60s, okay. What is the expected cardiac output in this patient? Normal is 4 to 8, so 3, sure, let's say 3.5. So what is the PVR here? Mean PA was, كم كان المين PA? 40 minus 20, the wedge, over 3. So 20 over 3, so PVR would be 6. So in this case, does this patient have pulmonary hypertension? Yes. Does this patient have pulmonary artery hypertension? It's post-capillary, so we call it post-capillary pulmonary hypertension. Why we say that? Because the wedge pressure was 20. So we probably call it pre and post-capillary pulmonary hypertension. Why did we say pre and post? Because the PVR was high, so that's the pre component. And the post, because the wedge pressure was high. So in this case, we have pre and post severe pre and post capillary pulmonary hypertension with reduced cardiac output. Okay, so with that, I think we reached our conclusion, and I'm happy to take any questions. اتفضل دكتور.
Is it working? Yes. Which specific RVSP should we send the patient to do RHC? I mean 30, 35, 40.
Oh, so it's not a specific number, but it's about the totality of all of the workup that you have. Meaning, you have 70-year-old patient with diabetes, hypertension, and RVSP of 50, and evidence of HFpEF. You don't really need to go for right heart catheterism because probably you have the answer, right? But if you have someone with scleroderma, an RVSP of 35, and they have some symptoms with exertion, that patient, although they have lower RVSP, the index of suspicion is way higher for precapillary pulmonary hypertension. So I would have lower threshold for right heart catheter. So it really depends on the patient in front of you rather than a specific cutoff.
Okay, thank you.
Abdullah, can you in 1 or 2 minutes elaborate on vasoreactivity tests for the group?
Sure.
So,
So one thing that we do in right heart catheterization procedure is called vasoreactivity or nitric oxide testing. And the reason we do that is we are trying to detect those patients who have what's called vasoreactive pulmonary arterial hypertension. Vasoreactive pulmonary arterial hypertension patients have a unique feature in that they respond to calcium channel blockers as their mainstay treatment of choice, as opposed to other vasodilator therapies. So in order to detect those patients, we do this vasoreactivity testing in the cath lab, and we're trying to demonstrate to see if there is any reduction in the mean PA pressure when we administer nitric oxide or some other agents, but most commonly nitric oxide. So what we do is, so it's only indicated in patients who have idiopathic PAH, drug-related PAH, or hereditary PAH. It's not indicated for those with connective tissue diseases or left-sided or group 3, group 4. So once we identify the right patient, then we go and administer this nitric oxide inhalation for like 3 to 5 minutes, and we monitor the PA pressure. So if the mean PA pressure drops more than 10 points to a degree less than 40 millimeter mercury with normal cardiac output, then those 3 criteria will classify this patient as vasoreactive PAH. So now we can label the patient as vasoreactive, and instead of giving them all of the fancy medications that we're going to hear about all over the next 2 days, we can just treat them with high-dose calcium channel blockers. Of course, this is a more complex topic that has lots of like small details and nuances, but basically that's what vasoreactivity is. And again, remember the indications: idiopathic, hereditary, and drug-related.
Hello. For patients wherein the mean PA pressures to start with is 30, how do you interpret the vasoreactive response?
So mean PA pressure of 40. So again, they have to drop to a value of less than 30.
No, if it's, I have a patient wherein
Yeah.
the mean PA pressures were 30.
30.
Yes.
Uh-huh.
So how do you interpret the
Yeah.
vasoreactive AD test
Yeah.
in that?
To be honest, it is very unlikely for someone who's vasoreactive to have a mean PA pressure of 30. Usually it's a more severe form of pulmonary hypertension. So usually their mean PA pressure is in the 50s. So if it's less than 30, I would question it would be a very remote possibility that this is a vasoreactive PAH. But if you can drop it to less than, I would say, again, these numbers came up from just people like me and you and looking at the data and coming up with.
No,
So
mean
if
PA
you drop
pressure
it,
is absolutely normalized post.
yeah, if it normalizes,
so
then
could we consider as a responder who was caught early, and could we initiate her?
as long as you maintain your cardiac output. So make sure that your cardiac output remains the same and your wedge is the same.
Yes.
If that's the case, then yes, you met the definition.
Thank you.
Thank you very much. You gave an excellent talk. My question is, when you are giving in fluid bolus of 500 ml, is there any duration?
Yeah.
You want to give it over 5 minutes, 10 minutes?
Sure.
Or
So people have, again, there is no uniform agreed upon definition here. People have done it over 5 minutes traditionally. One thing else that you can also do is, a lot of people in the ICU do that. You can just do a leg raise. And if you do that in a minute or two, and if there is no increase in the wedge pressure, then it is unlikely that the fluid challenge will be significant. But 5 minutes is the usual time to give the 500 cc.
And thanks. And second thing is, does it make any difference if you measure saturation from RA, go to PA, or the other way around?
Yeah, so in general, I like to go and do my wedge pressure the first thing. Why? Because when you put your swan in, it is stiff when you do the cat. By the time, it gets softer and softer by the heat of the blood. So you have less ability to maneuver the swan gans when it's soft. So I do the most difficult pressure, which is the wedge pressure first, and then the rest of the pressures that are easy to do because you're just simply pulling back. So that's what I usually do.
Thank you very much.
No problem.
Thank you, Dr. Abdullah. For those patients who are taking diuretics and you are intending to do the RHC, do you intend to stop diuretics before that, and for how long?
Yeah, good question. And I think it depends on the patient. In general, I don't stop it. But if I see a wedge pressure that I don't expect, then I challenge the patient with fluid bolus. But I don't typically stop because you want the patient to be euvolemic to begin with. But again, if you see a wedge pressure of 10 in someone who's already on Lasix, I would challenge that number, and I will do a fluid challenge.
Somebody who's needing oxygen as home oxygen therapy. So, when you do the right heart cath, how do you go about?
Yeah, so two things here. We know that oxygen therapy reduces PA pressure, so I wouldn't advise you to stop the oxygen, but I will say that the patient PA pressure is probably higher when they are off oxygen than when they are on it. That's number one. Number two is be careful that your indirect FIC is not going to be very accurate, because you really need to have a stable conditions and steady state of oxygenation, which is not the case with someone on oxygen, in order to have a valid and accurate interpretation of the indirect FIC method.
Those who predominantly have lung conditions.
Yeah. So I would advise you to do thermodilution in those particular patients, and I would not stop the oxygen. I'll just do it and interpret the numbers and just label them as those numbers were taken on oxygen. So people would understand that if you stop the oxygen, the numbers will probably be even worse.
I also have patients wherein they get referred after being on pulmonary vasodilators. Many of them, I've even had being initiated on endo block without a baseline study that they have. And then now when I do the echo, I really don't get any TR gradient or increased systolic pressures. So when I subject them to a right heart cath, to even know if it was started for the right indication, so how do you even address these group of patients? Because they are being put on medications without clear indications, and then they are on it for a year or two, and then they come to you now. How do you go about it?
Yeah. So the question is, someone who was started already on PH medication by someone else without a proper right heart cath, baseline right heart cath, and now they're coming to you and you're wondering, should we continue? Should we stop? What should we do with the right heart cath? Do we stop the medication? So unfortunately, this is a common practice. So in general, we like to say that no one should be ever placed on pH vasodilator therapy without a right heart catheterization. That's number one. But we know that's not the case in real life. So again, I'll take it case by case. If the echo shows no signs of severe PAH, meaning RV volume is small, RV function is good, no TR, and the patient is only in one medication, again, I don't know, it's a case by case. I tend to do it on the medication, and if I get reassured by the numbers, then I can gradually wean down the medication and then maybe repeat another right heart cath when they're completely off the medication. So, yeah, I see your point. There is no definite answer to that. I think it's a case-by-case scenario.
Thank you.
Dr. Abdullah?
Well, you want me to answer this?
Yes, please, go ahead. Let's take your opinion.
Yeah, so we see this in the practice, and so with these patients normally are either wrongly diagnosed or maybe they were properly diagnosed based on the clinical judgment but not based on the hemodynamics. So what we do, if the patient is really sick, we don't stop the medication, we do the right heart cath on the medications. If the patient is really stable, and this is the majority of patients, we actually hold them for 1 day or so, and we do the right heart cath, inclusive radioactivity, without the medications. So as Abdullah said, it's case by case. You have to really use your clinical judgment for these cases. Abdullah, thank you so much. I really enjoyed every single minute of this, workshop. Thank you so much. I'm also happy for the very good number of attendance, excuse me. And I know you've been here for almost 2 hours now, so we'll give you 10 minutes break. The coffee is next door, but please come back. You don't want to miss Olivier Sitpon workshop. It is going to be risk stratification based on clinical case scenarios. So you don't want to miss this opportunity. So 10 minutes and come back, please. Thank you. الحمد لله على السلامة. الله يقويك. دائما طبعا يؤاد فاليو في جيتك يعني. session of our workshop. This year can we stop the side talks, please? We need to start. So we decided to do a practical case approach, and the best scenario would be obviously conducted by our friend and colleague, Professor Olivier Sitwan. Risk stratification calculation for patients who have been seen in pulmonary hypertension clinics on weekly basis or daily basis is very essential in making the right decision for treatment. I think this is obviously step number 2 after making the appropriate diagnosis is to do the right risk stratification. And who is better to do this for us than Olivier? Professor Sitwan is a professor of pulmonary medicine from South Paris University. He is an international landmark figure for pulmonary hypertension specialty. He's been, of course, a leader for many clinical trials. And he will lead us through a case scenario for risk stratifications for patients with pulmonary hypertension. And according to the risk stratification will be the choice of treatment. And obviously this will be parallel with having proper assessment in terms of clinical assessment and hemodynamic assessment. So Olivier, please.
Thank you very much, Abdallah, for your very kind introduction. Always a pleasure to be here, and every year it's a real pleasure. I would like to repeat it again. So before considering 2 cases, I prepared 2 cases for you. I would just like to remind you quickly the importance of risk stratification, and also I would like to show you some new data we have. You are the first in the world, so I wanted to share this with you before looking at the cases. So just my disclosures. So a very simple first slide. What are the objectives of risk assessment? 3 steps. First, predict outcomes. Number 2, guide therapy, and define treatment goals. If you look at predict outcomes, we know that risk assessment may predict outcomes at baseline and at follow-up. There are plenty of literature on that. And the number objective, number 2, is to guide initial therapy. Initial therapy, it's very simple. We just have to identify the high-risk patient at diagnosis. It's not necessary to have a very complex assessment of the risk. We just have to know who is at high risk and who is at non-high risk, rather than to say low or intermediate, because we just have 2 options, either double or triple combination therapy. You know this by heart. This is the risk stratification table, including many variables. It's very comprehensive, but maybe it's a bit long, and perhaps we don't need all the tests to assess the risk. However, we know that it is very simple, it is workable, and it is sufficient to predict outcome. With just 4 to 6 variables, we can assess the risk at baseline and at follow-up. This is at baseline in the Swedish registry and in the Compera registry. You know those data. I don't want to spend too much time. However, among the objective of risk assessment, we have also to define treatment goals. And the treatment goals are so different if you are a physician and if you are a patient. If you are a physician, of course, your main goal is to improve survival, to reduce hospitalization, to improve RV function, etc. If you are a patient, we can say it is exactly the opposite. The patient wants to improve quality of life, improve the daily life activity, to tolerate the medication, to avoid hospitalization, but the patient, they don't care about the improving RV function, for example. So when we discuss about treatment goal, you know that the only acceptable treatment goal is the low risk status. And this is the European guidelines. And to assess this and to know if a patient is at low risk, at goal, at treatment goal, we have a very, very simplified method to assess the risk using non-invasive variables like functional class, 6-minute walk distance, and biomarkers like BNP or NT-proBNP. And with a very, very simple table, we can calculate and assess the risk status of an individual. And it works. This is the data from the Compera registry and from the French registry showing that with this, we can clearly assess the risk as low, intermediate high, or high risk. And we also know that it works in different forms of PAH, in idiopathic, irritable, or anorectic drugs-associated PAH, but also in connective tissue disease-associated PAH. Maybe in some other forms of PAH, like portopulmonary, for example, it doesn't work so good. So if we consider the risk, and the next step is to consider treatment escalation for the patients who are not at treatment goal, who are not at low risk. However, we have some gaps in evidence on that. We have some gaps in evidence, which is, do we need more granularity using, for example, other risk score, like REVEAL or REVEAL Lite? Does it a need for risk stratification in this patient for comorbidities? Because in the guidelines they said, we don't care of the risk stratification in comorbid patients. Which place for other tests like MRI or echo? We will have a talk on MRI tomorrow. I saw that on the program. And which place for right heart cath at follow-up? Do we need more granularity? We look in the French registry and we found that irrespective of the score you are using, we have exactly the same discrimination. The C statistics are exactly the same using REVEAL 2 or REVEAL Lite 2 or the 3-strata model at baseline or the 4-strata model at follow-up. So it's not a matter of risk score. The performance are really similar. Do we need recertification for in patients with comorbidities? You know that in the guidelines, there is no recommendation to use the risk to start a treatment. Also in the French registry, that's new data as well, we look at the C statistics and we found that finally the patient without comorbidities or the patient with cardiovascular comorbidities, finally the performance of risk stratification is quite good. It is as good as in patients with comorbidities as in patients without comorbidities. Which place for echo and MRI? I don't want to spend too much time on this. You know that in the guidelines, the transthoracic echo and MRI, it may be considered at follow-up, and also it is recommended in other at baseline and also in case of clinical worsening. We know that we're using, for example, the TAPC, PAPS, the ratio of TAPC by systolic pulmonary arterial pressure, this may help to assess the risk. This is data published from the French registry showing that using this variable is a possible alternative to the model based on functional class and 6-minute walk distance and NT-proBNP. And however, there's a lack of discrimination between the two top survival curves. If you have two variables in the green zone or 3 variables in the green zone, it's about the same. So finally, TAPC ratio is not discriminant in patients at low risk. It could be useful in patients at intermediate risk, but not at low risk. And you will see that we have very, very similar results in patients with right heart catheterization. Some others, they showed that, for example, TAPSI or other tests may help to discriminate the intermediate risk at follow-up. I don't want to spend too much time, as well as the MRI. We know that MRI may help as well, but we will hear tomorrow the talk of the colleague showing that. And finally, and this is very new, which place for right heart cath at follow-up? Which place for right heart cath at follow-up? This is a very important question, very, very important question. We know that at follow-up, right heart cath is just, it is mentioned, should be considered, or may be considered. So it's not a very top recommendation. However, we have some data from, it was published more than 10 years ago, this paper from the United States, showing that when you use just the non-invasive assessment like functional class, walk test, and labs without NT-proBNP, the C-index was lower than if we add right heart cath in the assessment of prognosis. That's why we decided to do the same in the French registry. In the French registry, we analyzed each hemodynamic variable in each risk status. We took the patient at follow-up, and we look at the risk according to the ESC ERS or the comparative. Comparative is a very bad wording. It is ASC ERS guidelines risk assessment. We do that, and we stratify the patients at low, intermediate high, or high risk. And we look at what were the added values of the different hemodynamic variables on top of the non-invasive assessment. And very interesting, we found that in patients classified at low risk with a very, very simple assessment, functional class, walk test, and BNP, there is no added value of hemodynamic variable. Nothing. It adds nothing. All the p-value are 0.5, 0.6, nothing. On the other hand, in patients at high risk, the most severe patients, patient functional class 4, very high NT-proBNP, it is the same. No added value of hemodynamics. However, in between, patient at low risk, intermediate low, or intermediate high, there is an added value of some hemodynamic variable. We can say almost all hemodynamic variables. And according to this, we apply a time-dependent ROC to determine the best cutoff of each hemodynamic variable within the intermediate risk groups. And we found, very interesting, we found about the same threshold that have been proposed in the guidelines. Right atrial pressure, 8. Cardiac index, 2.5. PVR, around 5. Stroke volume index, 37. SVO2, 65. Very, very interesting. And finally, because all those variables are linked, the collinearity between the different hemodynamic variables, we did different multivariable model, and we look at the IKK information criteria, that the lower the better. And we found that the best model was when we put just the mixed venous oxygen saturation on top of the non-invasive assessment to determine the outcome and the risk, which is very interesting. That's why we propose this algorithm for patients at low risk. No need for hemodynamics. High risk, no need for hemodynamics. And in between, we have to look at the stroke volume index and/or mixed venous oxygen saturation. It is enough to determine the low risk or the high risk, and in between we have the intermediate. And it is very discriminant, as you can see here. We have now 6 curves with a very good granularity. However, we don't know if, in terms of treatment decision, if this will impact treatment decision or not. We don't know, but it is interesting. And when you look at the comparison of the 4-strata model versus the new model, we have an advantage of the 3-strata model. That's why I would like to summarize with you in these first 15 minutes before looking at the case. So I can summarize to say that all models are equally good. Here, ESC, RS, recertification, Reveal 2, Reveal I2. It's a big fight with my friend Ray Benza about that. That's life. Risk certification is also effective in patients with comorbidities. Echo and MRI, they have a better discrimination in patients at intermediate risk only. And also, right heart cath, there is no added value in patients at low or intermediate risk of mortality. So my proposal is to say that the right model is 1 strata, 1 treatment strategy. So at baseline, high risk versus non-high risk. At follow-up, we have something to propose at low risk, intermediate low, intermediate high, or high risk. That's good. At diagnosis, high risk versus non-high risk, what I said, and at follow-up, the model with 3 non-invasive variables, it's usually sufficient, and other tests like echo, MRI, and right cath are of little use in improving discrimination, but just a little. Okay, case. Now, I think it was important to show you this very new data we just had. The paper is submitted now, so that's why I take the opportunity to show you for the first time. So, first case of Mary, 20-year-old female, no particular history, no cardiovascular risk factor, nothing, no exposure to illicit drugs, no tobacco, no anorectic drug, nothing. So she complained of shortness of breath for 6 months, and she was referred in a private practice cardiologist 1 month earlier. And this cardiologist suspected pulmonary hypertension on the data you see here. Finally, the patient was examined by the cardiologist, and she complained of dyspnea at mild exercise. She was in functional class 3. This is the data. The blood pressure was normal, heart rate 90. She had a jugular distension, some mild leg edema. The chest X-ray showed very typical features of pulmonary hypertension with cardiomegaly, pulmonary arteries enlargement. And finally, the transthoracic echo clearly suspected pulmonary hypertension with an estimated right ventricular systolic pressure of about 75, an RV dysfunction with a TAPC of only 14, mild pericardial effusion, and of course, dilation of the right chambers. Finally, the patient was referred and we performed a right heart catheterization, showing the right arterial pressure of 16, mean PAP of 40, wedge pressure of 6, precapillary pulmonary hypertension, cardiac index was decreased, 1.6, SVO2 59%, and the PVR were elevated more than 13 Wood units. After nitric oxide, there is no change. We can consider that this patient was non-responders. We complete the workup with blood samples showing elevation of NT-proBNP. Otherwise, it was unremarkable. 6-minute walk distance, 265. Pulmonary function test showed normal volumes and flow and slightly decreased DLCO and also a slight decrease in PaO2. Angiosity of the chest, there is no lung or no evidence of no lung disease or no evidence of PVOD. You can see here the right atrium and the right ventricular enlargement and also a mild pericardial effusion. A VQ lung scan is mandatory to rule out CTEPH, and it was done. And also, she had a normal liver ultrasound to rule out portal hypertension, and finally, she didn't have any genetic mutation. So the final diagnosis was idiopathic PAH, non-vasoreactive, with a severe hemodynamics at presentation. My first question for you is, what is the risk of mortality at 1 year in this patient? Is it low, intermediate, or high? What do you think? Who wants to reply?
It's high, clearly.
High? Everyone? Who vote for low? Who vote for intermediate? Who vote for high? There is no one. The count is not there. All right. We have to look. First, is this patient had this patient cardiopulmonary comorbidities? The response is no. So we have to look at the risk assessment to consider the treatment strategy. If you look at the data, if we apply the same method that is proposed by the guidelines, she's functional class 3 plus 2. Walk distance 265, it is between 165 to 440 plus 2. NT-proBNP 1800, 3 points. Mild pericardial effusion, 3 points. Rotatorial pressure, 3 points, etc. We summed all those scores, and the scores at the end is 2.75, and we rounded to the nearest integer, is 3. 3 is high risk. This patient, she's at high risk of mortality, more than 20% risk of mortality at 1 year. You're right. So we decided to initiate triple combination therapy with IV epoprostenol, bosentan, and tadalafil. And then we reassess the situation after 4 months on triple combination therapy. She was treated with 16 nanogram per kilo per minute for epoprostenol, bosentan 125 BID, and tadalafil 40 milligram once a day. And this is the results. She was in functional class 2, walk distance markedly increased, more than 500 meters. Mean PAP decreased to 29. Rotatorial pressure totally normalized. PVR decreased by 72%, from 13 to 3.7. Mixed venous oxygen saturation markedly improved. Stroke volume index, as you can see, multiplied by 4. And NT-proBNP also normalized. So, now the question is, what is the risk at this first evaluation on therapy? Is it low, intermediate, high, high? Low? Who say low? Low risk. Abdullah. Only you. Intermediate low? Who said intermediate low? No one. Intermediate high? Okay. And high? No one. So we have Abdullah for low risk, no one for intermediate low, some people for intermediate high, and no one for high. If you look at this, I'll show you again, but you know that. Everything is in the green. Class 2 in the green, walk test in the green, BNP in the green, just with these 3. That's what I said previously. With these 3, class 2, 1 point. Walk test more than 440, 1 point. NT-proBNP less than 300, 1 point. 3 points, 1 low risk. Okay? What is the added value of hemodynamics? Nothing. But we did it. So she's all in the green, and we know that the more the low risk criteria had follow-up, the better the patient outcomes. We showed that with a Tenais booklet in 2017. So, and then we continue to reassess. the patient. And we reassess non-invasively, just with functional class, work test, NT-proBNP. That's just outpatient consultation. Discuss with the patients. How do you feel? How is your life? What are your daily activity? That's very, very important. Work test, just for 6 minutes. NT-proBNP, just blood puncture. Very, very easy. And with these three, you can say, okay, that's fine. Sometimes we did CPET, which is confirmatory. Sometimes we did echo, which is good, it is just reassuring. And in these patients, honestly, we don't need additional right heart cath. We don't need. If something occur, something like, for example, slight increase in NT-proBNP over time, or slight decrease in 6-minute walk distance over time, I think you have to say, okay, something wrong is occurring, I have to do something else. Echo, CPET, right heart cath, maybe MRI if it is available. Right? I think it's very, very illustrative of how to use the risk assessment in this very, very typical young patient. Any question before? Or I show the case number 2 and we can discuss at the end. We have time. All right. Patient number 2. A female patient born in 1953, and she was referred in 2016. She had 64-year-old. But her personal history was much more things. We found much more events than in the other case. In the past, she had rheumatic fever, she had COPD, a mild COPD because she was a former smoker. She had diabetes induced by steroids. We don't know exactly why she received steroids. She was obese, and she also had a hysterectomy for cancer. In June 2013, she had an acute coronary syndrome because she had chest pain and some ECG abnormalities. And she had a coronary angiogram, and she was treated with a stenting. And finally, in June 2015, she had obstructive sleep. She was diagnosed with obstructive sleep apnea. In December 2015, she had an acute pneumonia. And finally, during this episode of acute pneumonia, which is really an infectious disease, she complained of dyspnea, but it was in some part related to the dyspnea. But she had a persistent nocturnal hypoxemia, despite the good outcome of the pneumonia, and she complained of shortness of breath. And finally, she had an echo, a new echocardiography, and at that time, she was suspect with pulmonary hypertension. She had a right heart catheterization in another hospital, showing a wedge pressure of 25 and a pulmonary artery pressure of 75 for the systolic, 35 for the diastolic. No additional information. It was possible to have a post-capillary regarding the history of this patient. So finally, she was referred to the center, to the expert center on oxygen. She had a persistent dyspnea, really poor quality of life, and so finally we decided to perform the full workup. We do not stop at the diagnosis of post-capillary pulmonary hypertension due to left heart disease. This is the treatment she received: diltiazem, statin, fenofibrate, metformin, aspirin, etc. So on physical examination, so she was obese with a BMI of 40, normal blood pressure, normal heart rate, the saturation was fine on oxygen, and she just have a peripheral edema. This is the ECG showing a sinus rhythm and incomplete right bundle branch block. And this is the data from echocardiography, clearly suspecting pulmonary hypertension with right ventricular strain and right ventricular phenotype. And that's why we decided to continue in the workup up to right heart catheterization. The blood analysis, there is no renal insufficiency, the hemoglobin was normal, anti-proBNP was slightly elevated, not too much, slightly elevated. Arterial blood gases showed hypoxemia, 50, and hypocapnia, 27. And the autoantibody was negative. Pulmonary function test, the volumes and flow were slightly decreased. It is very, very common in obese patients to have this picture. And the DLCO was around 40% of predicted. The CT scan ruled out pulmonary veno-occlusive disease because there was no septal line, no pleural effusion, no abdominomegaly, there was no emphysema, no fibrosis, nothing. And the VQ scan was negative. 6-minute walk distance, 180. And the CPET, we also performed a CPET, which was very, very severe, and she was not able to have a good workload, just 15 watts, which is almost nothing. And despite that, she had the slope of VEVCO2 was very, very steep. That is very typical. So after this non-invasive workup, there was a high probability of pulmonary hypertension with evidence of RV strain or dysfunction, with severe functional impairment, with cardiac limitation on exercise, important comorbidities and risk factors for pulmonary hypertension. And the phenotype was much more in favor of post-capillary pulmonary hypertension, but the echo was more suggestive of RV precapillary phenotype. So we did a right heart cath, and this is the right heart cath. The mean PAP was 49. The wedge pressure was around between 7 to 15 according to the ventilatory swings. And if you look at the end expiratory, that's 15. If you look at the mean or the average, it's 9. How to consider that? Sometimes it's difficult. Anyway, so she had a very low cardiac output or cardiac index and high PVR. So that's why we decided to confirm the precapillary pulmonary hypertension by doing left heart catheterization. And we also take a look on the coronaries because she had a stent. And finally, the LVEDP was just 12, not 15. So it's clearly precapillary pulmonary hypertension. To be sure, we do an acute fluid loading, 500 mils of saline in 2 minutes. It's a very, very big stress of the left ventricle. And post-loading wedge pressure was just 50. Clearly, it was a precapillary pulmonary hypertension. We also test vasoreactivity with nitric oxide. There is no response to nitric oxide. And this is the final report of the hemodynamics. Mean PAP was 51, no change or no significant change with nitric oxide, 51 to 43, very low cardiac output or cardiac index, and high PVR. So, it is a typical case of the pulmonary arterial hypertension with comorbidities. This is not a post-capillary. Because in terms of hemodynamics, we have a wedge pressure of less than 15, LVEDP 12, PVR was very, very, very elevated. We exclude other forms of precapillary pulmonary hypertension. And this patient had significant comorbidities with metabolic syndrome, apnea syndrome, sleep apnea syndrome, and also coronary artery disease. I have three questions in one slide. Very simple question. Do you need to assess the risk in this patient's comorbidities? Remember what the guideline says. The guideline said we don't have to look at the risk in those patients. We just have to give sildenafil. What do you think? Do you need to look at the risk? Yes, I agree. I think it's yes. We have to look at the risk in this patient. Otherwise, you will probably miss something. Does it impact your treatment strategy? Yes. Probably yes. If you follow the guidelines, you just give tadalafil or sildenafil. Is it your strategy for this patient? I think it's a loss of chance if you do that. So, which kind of treatment strategy? What do you think? Monotherapy with PDE5, monotherapy with an endothelin receptor antagonist, double oral combination therapy, double, triple oral, triple combination with IV or sub-Q? What do you think? Who has an idea? Take the mic. With comorbidities, you said? Yes, the guideline says monotherapy. Which monotherapy? Phosphodiesterase. PDE5? PDE5 inhibitors. So, okay, that's a response, okay? She's very severe. PVR 13, cardiac index 1.6 or 1.5. NT-proBNP, that was okay. Monotherapy.
Optimize her lung therapy as well as her heart failure therapy as well. And then
well, her lung.
She has severe sleep apnea by that.
Yes, yeah. No, it was controlled. Sorry, maybe I missed it, but the sleep apnea was controlled. It was controlled. Personally, I think that we have to consider this patient with or without comorbidities in the same fashion. So, personally, and that's what we did. Because for this patient, what happened? Does it work? It doesn't work? Ah, okay. If you look at the risk, it was that one? Yes, okay. If you look at the risk, this patient is, you can say, intermediate high or high risk. Probably high risk in this patient because the CPET was very, very poor results and the hemodynamics was very, very severe. She has a very, very severe hemodynamics. So in this patient, we consider triple combination therapy as a young patient without comorbidities. We initiate double and then very quickly we add IV epoprostenol. And finally, when we reassess after 4 months, she was in functional class 2, the 6-minute walk distance improved. Okay, 350, but 350 for a 65-year-old obese with comorbidities, it's not so bad. It's not so bad. NT-proBNP normalized, and there are some change on echo. And finally, when we recat her, after 6 months, the cardiac index was normal, the stroke volume index was normal, right atrial pressure decreased, PVR decreased from 13 to 6, and mean PAP 43. So, if you look at the risk in this patient at follow-up, now she's at low risk. She's functional class 2, 1 point, normal BNP, 1 point, and despite the quite non-perfect 6-minute walk distance, okay, 2 points, it's 4, it's 1.23, it's 1, it's low risk. So I think this case illustrates that also in patients with comorbidities, we have to be very cautious with the guidelines. And I think in the next recommendation, we have to work on that, because otherwise, if you just give monotherapy and we see what happens, there is a big risk of loss of chance in patients with comorbidity. So those patients, they have true PAH. Okay, they have coronary heart disease. Okay, they have obesity. Okay, but that's a true precapillary pulmonary hypertension. If you do your best to rule out postcapillary, you are sure that this patient had group 1 PAH. This patient had idiopathic PAH. And she also has obesity, she also has coronary heart disease, she also has dyslipidemia, etc. I think it's very important to consider that. When we say PAH with comorbidity, for me, that's not an entity, it's just rare disease, PAH, that is associated with other very common disease. Okay, these common diseases may impact the tolerability of the treatment, that's right, but in terms of treatment decision, you have to consider that this patient, she has a true PAH. And it is important to consider that to give the best possible treatment. I think I've finished. I'm sure I've finished. And we can discuss now.
Thank you so much, as usual. Very enjoyable, and thank you for making us the first to share your newest information. Thank you. We can receive a question and answers, but the last patient, Olivier patient, illustrate how much clinical decision is very important for patients. If you want to go by the book, by the guidelines, you give only monotherapy for this patient, you don't even do risk stratification, and you go on. But I can give you the same clinical scenario, Olivier, exactly the same, Faiz patient, I don't know if Faiz here, with a wedge pressure of 7. Wedge pressure of 7. But with all these comorbidities, you know, left side heart disease, history of coronary cath with stenting, hypertension, metabolic illnesses. But her wedge was very low. She had cath twice, just to double check whether the original cath was appropriate. And she was given monotherapy, and only a week later, she came to the ER with pulmonary edema. So again, a clinical judgment for patient is very, very important, but this patient, without being given the appropriate treatment, she would have lost, a very good chance for survival.
Yeah, I think at the initial management, when we have a doubt, at the initial evaluation, you have to do our best to look at the left ventricular function, if there is something wrong or not. I think the free challenge is important. I think it helps because after 500 mils saline, very quickly, if you don't have any change or no significant change in wedge pressure, you are quite comfortable.
Questions?
Yes.
Yeah, go ahead.
Thank you so much. And I totally agree with Dr. Will, and he said that the patient had a wedge of 7, and then she came after a week with pulmonary edema. It's very hard to call this call, to be honest, because the hemodynamic of the patient reflects his hemodynamic at that day, not the hemodynamic throughout the past month or past years or past few years. There are so many patients with advanced heart failure and very high wedge pressure, with chronic left-sided filling pressures, with very severe pulmonary hypertension, but because the minute you start to diurese them, their wedge become normal, but they're still left with the precapillary component, which will not improve as fast as improving the wedge pressure. So presenting such case, it makes me a bit frustrated because I'm an advanced heart failure cardiologist. like most of the time, this case will be post and pre-capillary pulmonary hypertension, like 99% of the time. The only one time maybe your case, to be honest. So, like, let's not just forget that 80% of all PH patients is due to left heart disease.
No, I agree. I agree. That's why I said that it is very, very important to have a very accurate evaluation at baseline. And if you have doubt, if you have comorbidities in an obese patient with coronary heart disease, with hypertension, with some degree of left atrial enlargement, for example, you have to check for that, and you have to stress the heart during the right heart cath. I think fluid challenge or exercise is good too, is very, very important. Very, very important. If you don't have any increase in wedge during exercise or no increase in wedge during fluid challenge, no more than 15, I think you are quite good. So, but sometimes you also have patients with pulmonary veno-occlusive disease. Patients with pulmonary veno-occlusive disease, they have a normal wedge, and presentation sometimes similar, yes. And you give drugs and they have pulmonary edema. So I think we have to be, yes. It's very important to have a complete evaluation.
Thank you so much for this amazing workshop. My name is Raghda, I'm one of the pulmonologists. So my question to you, so we see pulmonary hypertension, female, young, they're not limited in walk to start with, but they have severe hemodynamics. So I will always get thrown off by the severity of the hemodynamics. So we cath them and they have significantly high mean pressure, very high BVR, more than 10. And then if they have an idiopathic disease, they're non-vasoreactive, we have to do risk stratification, and then we start these people or start these women on a treatment, for example, double therapy. But I always have this feeling when the hemodynamic is that severe, you might have actually a very low threshold of considering triple therapy. So how would you approach somebody like this? Already started with a good walk, already started with class 2 symptoms, but the hemodynamic is very concerning. We're talking about mean pressure more than 60, BVR more than 10. What do you think?
No, I agree. In young patients, sometimes we have this disconnection between hemodynamic, which is very severe, and finally symptoms that were quite preserved. If you consider that a 20 or 25-year-old female or male walking 450 is good, no, it's not good. 450 is very, very low for a young guy or young female. Very, very low. So I think we have to be very cautious with that. But usually, we also have a marked increase in NT-proBNP. NT-proBNP for me is very, very important because functional class is really very subjective and walk test as well. So I think NT-proBNP is very, very important. And if you have very severe hemodynamics, high right atrial pressure, low cardiac index, usually NT-proBNP is elevated, and you have to think about triple combination therapy in those patients. Okay, sometimes it's difficult to convince the patients because she said or he said, I'm feel good. But at the end, they do not feel so good. So, no, I think if you are very convinced, if yourself is very convinced, it's not so difficult to convince the patient.
Thank you very much. I'm Hanan Fran, pulmonologist from Jeddah. I don't have a question, just a comment. Thank you for bringing such case, the second case, because now we face a lot of similar cases with comorbidities. I think the guidelines and the algorithm writing that the comorbidities to be treated with monotherapy need to be more clarified, that to be more cautious in investigating and investigating such cases. And to be sure of the diagnosis in case of comorbidities, and then having the other comorbidities in stable condition, as one of the doctors mentioned here, that having sure not left heart disease and the other sleep apnea and all these are stable, then to start but if we are sure that it's PH, then you follow the same
No,
strategy.
sure.
Yes.
I totally agree. Totally agree. We have to fix all the other problems before concentrate on PAH. I agree. I agree.
If you follow the algorithm, you're going to start monotherapy.
No, I agree. In the
Yeah.
algorithm, there is no mention of the control of comorbidities. I think it's very, very important because if you have a patient with a hypertension of 200 for the systolic, and you have first to treat that before considering the PAH.
And these are very difficult because even the right heart cath and you need thorough investigation and assessment because having the pitfalls in the cath and then knowing exactly there is no evidence of left heart disease. So you need to be really careful. In
No,
this.
sure.
Yeah, thank you for bringing it up.
I agree, and we are working on that for the next, not guidelines, for the World Symposium.
Great. Now, what do you do with this newest data of yours? Now, you subdivided the intermediate to another smaller groups, low, intermediate, high.
I don't
high.
know.
So what's the clinical use of this now?
I don't know if we will do that, but what is very interesting in the data I showed you, that for low risk and high risk, we don't need something else. I think it's you just have a very simple evaluation and you can determine if the risk is low or high. In between, today, we don't have multiple choice for therapy, but with availability of sotatercept, with availability of maybe PDGF inhibitors, we will have the choice in those patients at intermediate risk. We will have the choice with selexipag, switch to Rio, add sotatercept, add maybe an inhaled drug. We don't know, and maybe we think that maybe in the future we will have different approach according to the risk. We don't know today. Well, I agree that today it's very simple. We add selexipag or we add IV or sub-Q. Yes. So it's we will see. I think, but it's interesting for me for the extreme, for the low and high risk.
And it's also reassuring for us as a clinician because real life practice, when you see a patient going into intermediate high or high, and you always wanted to do hemodynamics. But now, knowing that the hemodynamics will add nothing for the higher risk group, you just start your, prostanoids.
Yes, I agree. But if you want to add a proportional, you will do an hemodynamics just to see what happened on therapy.
That's what we do. Yes. Okay. Any more questions? Bilal, Pasha.
Thanks for such a fantastic talk. I think young patients, when there is a discordance between their symptoms and hemodynamics, then probably doing a CPET gives you a lot of answer because patients don't understand when you show them cath data. But if you do them CPET and you have VO2, VCO2, probably they understand better about the severity of the disease, and it also gives me also better idea where we are standing.
Sure, I totally agree. In particular, in patients with mild symptoms, if you do CPET, you are not surprised sometimes to have very, very severe exercise limitation. I think it's. I think we have to promote maybe more CPET in the future. But the problem is CPET. It is done it is performed in very, very selected centers. Not all centers they do CPET, but maybe we have to know how to use better the CPET. I agree with you.
Because we see these young patients and they come and ask me in my OPD, can I go for swimming? Can I go for bicycle? So it becomes very difficult for me to give them answer until I take them to CPET lab and see where they're standing. Thanks.
Thank you.
Well, I think we finished. By the way, online, there are nearly 300 people also attending with this great attendance. We are so happy that these nice workshops have its effect on people. Thank you so much, all of you.
Thank you, Abdallah.
The main program will start at 6:45, the opening remarks and the keynote speech, as well as the clinical leader review. Hassan has some remarks to say, and I'll see you at 6:45.
Very good. Thank you very much, Professor Dalan. As you know, in SAPH, we strive for excellence. And therefore, we made this evaluation form for the workshops. And we do have certificates specific for each one of those workshops. So kindly, most important is your name, the way you want it to be written in the certificate, and your email, so we can send it to you. And kindly fill up this evaluation. You can drop it as you go out. Thank you very much.
So please have a seat. I think there is an echo. Okay, now. Good, thank you. Have a seat, please. Okay, well, assalamu alaikum wa rahmatullah wa barakatuh. Good evening and welcome everybody to SAPH 2024. It's our 17th annual SAPH meeting. It really feels only a month ago or 2 months ago when I did the opening remarks for 2022. So time is really flying very fast. I had only a few slides for you so we can introduce you because we have newcomers here to have a few slides about SAPH, and then we'll go quickly over the program, the scientific program, and a few remarks, and then we'll start with our program. You know, the healthcare in Saudi Arabia is really diverse. We have different healthcare systems. So, for example, we have King Faisal Specialist Hospital as a stand-alone. We have Ministry of Health System, National Guard Health System, Military Health Care System, University Hospital, and Security Forces System. And in each individual healthcare system, there are criteria for eligibilities. But any Saudi citizen who has an advanced disease that requires the tertiary care center can actually be treated in anywhere of these hospitals. Colleagues of ours, namely Dr. Majdi Idris and Salih Damas and myself and some other people, actually we established SAPH as Saudi Association for Pulmonary Hypertension Society to govern or to be an umbrella under which the PH activities can be, as well as promote the awareness about the pulmonary hypertension disease among those who are interested in treating pulmonary hypertension, or those who we think are the frontliners to see patients with shortness of breath elsewhere in the country. And as you could see from the briefest map, the country is quite big. So in order to have 1 or 2 centers to treat per patient with pulmonary hypertension, it's really very, very difficult. We also have difficulty sometimes enrolling patients for international clinical trials. And the reason is majority of our patients are actually from outside Riyadh. So in order to travel from Tabuk, for example, or from Arar or from Jazan to Riyadh, in sometimes actually 2 hours flight. So the role of SAPH over the last 17 years, I would say, is not only promoting the disease awareness among physicians, but also trying to help in referring patients from small hospitals to the large tertiary care centers. So it was established actually in 2007, and it has a mandate. And I think what has changed the landscape of pulmonary hypertension in the country is SAPH. I would say this with no hesitation because colleagues who are actually representing SAPH are actually from different parts of the country. They are specialized in pulmonary hypertension, and they have done a great job in terms of educating their colleagues elsewhere in the country. So there has been what I call it a SAPH Awareness Day Outreach Program campaign. Over the last 17 years, hundreds of awareness days have been held in different cities of the countries. Normally in small hospitals, medium-sized hospitals, and sometimes in a place where we can get actually more people from different hospitals to attend. And normally it's a direct dedicated to education for general practitioners, pulmonologists, cardiologists who are interested in treating pulmonary hypertension. And as I said, I think thousands of people have already been educated for pulmonary hypertension. And you could see it clearly over the years how the referral rate from small centers in the country is increasing year by year, month by month sometimes. And we have noticed that when we do educational activity, let's say in Jeddah, the second week we get more referrals. So this has been happening over 17 years. And I think that's what has changed the situation of pulmonary hypertension in the country. We also do what we call it master classes, SAPH master classes, normally held in hospitals, where we get 10 to 15 people from different cities, small hospitals in the country, sometimes from the GCC countries as well, and we get them into the hospitals. We do direct teaching, of course, but also the right heart cath training. We also do, simple 6-minute walks training for those who are interested in starting prostanoids. We also teach them how to do the IV protocol, subcutaneous protocol for prostanoids. But also, they come to see the patients, real-life patients in the clinics. And seeing a patient in the clinic with a pump is always helpful to educate people about how to treat these patients. So this is also part of the activities that SAPH have been doing over the last 17 years. More recently, over the last 3 years or so, we started what we call it SAPH, SAPH International Outreach Program, where we also extend our help to our colleagues in the neighboring countries. We held our first international outreach symposium with our colleagues from Egypt. They're all here, and it was very successful. We had very good feedback. We also did one in Malaysia and India. Only recently in Hyderabad, we did a SAPH symposium within their international chest conference. It was in December. And we are this year in contact with Indonesia as well as South Korea. South Korean team will be joining us in the coming few days. So over the years, I think SAPH have done a lot in terms of education for doctors in the country. Even for patients, colleagues in the medical city, Dr. Hussam and his group, they used to do also to hold, organize patient education symposia, and that had happened several times before. And this is also very important for patients with this devastating disease to have been educated about their disease. This has translated into this. These are the attendees number for SAPH annual conferences over the years. We don't have data from the older ones, but we remember it's probably 100 plus minus attendees. And then it started to pick up. And more people became more interested in pulmonary hypertension, more doctors, and the attendees numbers have been increasing over years. And this is the Corona time when we first time used the teleconferencing facilities. And you could see that for the first year, and when we used the online live stream, we had 5,000 registration. This year, we have 17,000 registered. We're all surprised with this number. Whether Hassan will be doing analysis for this and see how many of these are doctors, how many cardiologists, pulmonologists, nursing, respiratory therapists. So we are so really happy to think that we generated such an important attention and interest among healthcare professionals in the country when we saw this number. And we expect, of course, as you could see, the attendance is very well, even more physical attendance. So having said that, this year also because it was successful last year, we did 3 workshops. You all attended that. We're very well attended and very successful. And thanks for our colleagues who conducted the workshops. Now let me just go quickly over the program. So the scientific committee, chaired by Dr. Ragad, have come up with very good, what we could think is a comprehensive program, covers most of the aspects of pulmonary hypertension. Several years ago, we started, putting together the first day of the conference. Normally, people just coming from their work and busy. There are late arrivals as well. So we decided only to put 2 talks. One is a keynote speech. And the subjects normally either directly related to pulmonary vascular diseases or somehow indirectly related, but with some future impact. And that's why this year, Dr. Fawzan Al-Karaya will be talking about, he's a genetist. He's trying to link between the pulmonary hypertension and the genes. He will be introduced later. And of course, we do also the clinical year review, and normally this is also for half an hour, and it covers most important landmark trials or studies that have been published the year before. This year, we have invited our colleague, American PHA, as well as European PHA, and as well as PVRI. PVRI has been with us for many years. They're good partners, and they have been dedicated and very loyal to SAPH for I think, the last 17 years or so. Today, after this session, they will come and introduce themselves and tell us about what they do. But at the end of the conference on Saturday afternoon, they will have a formal presentation about what really they are doing in terms of activities, how are they helping patients, both the BHA, PVRI, and BHA Europe. I think we're entering a new era in pulmonary hypertension medicine. I think for the first time, now we're talking about targeting non-hemodynamic targets for treatment of pulmonary hypertension. Maybe we're targeting the pulmonary vascular remodeling. And this year we put 2 sessions dedicated for the upcoming 2 new molecules that are targeting different pathways. So this will be covered tomorrow morning. And then we'll go into more of a group 3 pulmonary hypertension. We did not give a lot of emphasis on this subject a couple of years ago, the last year and the year before, but there is a little bit of data, new data, so we wanted to hear from people what they are doing now for their pulmonary hypertension, group 3 pulmonary hypertension patients. And obviously, normally we end the day with challenging clinical, real-life clinical cases. On Saturday, we have another more of a clinical PAH, different subjects, and normally we conclude the sessions, the program with CTEF session. And this year, as I mentioned earlier, we have a few colleagues who are coming from international societies, and they wanted to tell us about their experience in pulmonary hypertension and what activities they do. Few things, there will be a dedicated 6-minute walk test training throughout the program. If people are interested to learn something about 6-minute walk test, please visit our colleagues there. Please fill the forms for the evaluation as well as the Saudi Commission for those who need the CMEs. We have a 14-hour CMEs for this program. Between the sessions, we of course, the main session in the day, we have the lunch break, but between each session there is a coffee break. The coffee break is actually, we put it with the exhibition so we can also interact with the pharmaceuticals who have been supporting us. Please turn off your mobile or put them on mute mode, so we don't want to disturb the audience. And let me thank our partners. Without them, this event will not happen. As you could see, they have been helping us for the last 17 years. Janssen and Bayer have been main contributor to SAPH activities over the years. Thank you so much, Janssen and Bayer, and of course, our colleagues from the other pharmaceuticals. I think Hassan put this one to particularly thank PVRI because they have been very loyal to us for the last 15 or 17 years. So thank you, PVRI, on behalf of Hassan. Before I close, it is really my pleasure to introduce the first 2 chairs for this session. Dr. Saleh Al-Dammas, he is one of the co-founders of SAPH. He's a pulmonologist, consultant pulmonologist in military hospital, specialized in PH as well as sleep medicine. He will be chairing this session with Dr. Raghda Arif, our chairperson for the scientific program this year. Dr. is also a consultant pulmonologist from Jeddah, University Hospital from Jeddah. She kept changing, but I think you're from University Hospital, right? Okay, so they will start the program, and after that, you will be, we will get the questions and answers after the session completed. Thank you so much, and welcome again to SAPH. Thank you.
Assalamu alaikum warahmatullahi wabarakatuh. Good evening, everyone. I would like today to start our first keynote session. I'll be sharing this with my dear colleague, Dr. Saleh Damas, and he will be presenting our first speaker.
Thank you very much, Dr. Raghda, and many thanks to the chair of the meeting, Dr. Abdullah Dhalan, organizing committee, the scientific committee, for giving us the chance to be part of this well-respected international conference. And it gives me great pleasure to introduce the first speaker. He's a local and international figure in research, Professor Fawzan Al-Kraya. He's the chairman of the Department of Translational Genomics at the Research Center of King Faisal Specialist Hospital here in Riyadh. And he also holds a position of Professor of Human Genomics at Al Faisal University, which is a local university here in Riyadh. And he'll be talking about genomics in pulmonary disease, lessons from rare diseases in pulmonary medicine. Professor?
Working. Hello, can you hear me? Assalamu alaikum. Good evening, everyone. Thank you very much for the very kind introduction. It's a true honor to be among you tonight, dear colleagues. I have to thank the organizers, especially Dr. Abdullah Dhalan, for the very kind and generous invitation to be with you tonight. So let me say up front, I'm no expert in PAH. What I am, though, is a very passionate geneticist who firmly believes that genetics has so much to offer, no matter the medical or surgical specialty. And so when I was negotiating with Dr. Dhalan, what he had in mind when he invited me to give this talk tonight, he was very kind to give me the liberty to pick and choose any topic that I think would be appropriate for this audience. And so I thought I'd share with you a few snippets within the theme of precision medicine, which is all the craze these days, and to show you how we could really change the way we practice pulmonary medicine. And I'm not going to disappoint you. I will touch on PAH along the way. So what's special about personalized medicine anyway? You're all familiar with the 4 Ps of personalized medicine being precision medicine, rather, being personalized, predictive, preventive, participatory. But let's face it, it's not like in traditional medicine, we bring 20 patients, line them up in a single room, average them out, and then come up with a recommendation for how to treat patients. That's not how we do it. But in reality, if you think about it, that's pretty much what we do. So if you see a patient with bronchial asthma, for instance, as a pulmonologist, you don't order a bunch of biomarkers to classify your patient into a specific molecular subgroup to guide your treatment. You actually fall back on the average. You walk your way out of that average with a trial and error until you figure it out. And it's truly remarkable when you think of what the future generations are going to be thinking of this practice, and I'm sure they're going to be calling it malpractice, honestly. So what does it take to go to the level of precision that I'm talking about? Obviously, we need data. So precision medicine is a data-driven medicine. And of course, an important component of these data is genomics data. And so what we really need, if we want to realize the dream of precision medicine, is a system that fully integrates genomics with all the phenotypic data that you would be familiar with in order to guide the next generation of healthcare rather than sick care for our patients. So I mentioned the word genetics and genomics data, and I know this may be a cause of anxiety to some people, but let me try to simplify it a little bit. Because biology is messy, right? We know that biology is very, very messy, and genomics is no exception. But let me simplify it a little bit. And I want you to think of what happens if you were to sequence the genome of an individual. If I sequence your genome, I'm bound to encounter a very large number of changes, which we call variants. And these variants fall on a spectrum in terms of frequency. So on the one end of the spectrum, you have variants that are very, very common. They're shared by many, many people on the one end. And then on the opposite end of the spectrum, you have the very rare, even novel and private to that one individual that you're sequencing, not present anywhere else. And of course, you have everything in between. Now, if there's one must take away from my talk tonight, it would be this concept of the correlation between the frequency of the variant and its effect size, its impact. It would be easy for you to imagine that for variants that are very, very common and shared among a lot of people, these would be very unlikely to result in devastating disorders, right? Makes sense. It would be also easy for you to imagine that if you identify a novel variant unique to an individual who presents with a very rare genetic disorder, that variant could very well be the sole cause of that rare disease. But I want you also to reflect on the fact that this is not always true, meaning not all common variants are benign. And this is why we have common diseases like asthma and COPD and so forth. They're common because there are common variants shared among people that predispose them to these common disorders. And at the same time, not every novel variant is disease-causing variant. And that's why if you're caring for a patient with bronchial asthma, with cystic fibrosis, for instance, and you ask your lab to sequence CFTR, you could very well get a report with a question mark telling you that we've identified a novel variant, but we don't know if it's disease-causing or not. And of course, there is the bridge between the rare and the common, like the Mendelian forms of complex diseases. So let's go over these classes of variants and see how they can help us enable precision medicine. And let's start, as the title of my talk indicates, with rare variants. And obviously, I can't talk about rare variants if we're here in Saudi Arabia without talking about the concept of consanguinity and its huge implications on the landscape of diseases in the region. So because consanguinity, or marriage between relatives, is very common in our region, we frequently encounter this scenario depicted here on this slide. So what you're seeing here, and I hope the pointer would be working. Let me see. Is it? Yes, it is. So as you know, for each chromosome, we have two homologs, maternal and paternal, right? So I'm just simplifying it with a color code. And I just want you to follow the pattern of inheritance of this light blue homolog of this chromosome as it gets passed on from this individual to his two sons, and from these two sons to their son and daughter, who are now first cousin, right? And so if they're married, which is more than 50% of marriages and unions in Saudi Arabia, then there's a 25% probability that a child would inherit both copies from both parents. Now, if that haplotype happens to harbor a disease-causing recessive variant, as you can imagine, none would be affected by that autosomal recessive disease except for this unlucky child who is now not only homozygous for that variant, that individual is actually autozygous, a phenomenon that would not have occurred had the parents not been related. And so, as you can imagine, this translates clinically into a huge burden of autosomal recessive diseases in our society. And this also explains why we're very successful in characterizing these disorders by combining the power of genomics with the power of positional mapping, as you're going to see in a moment. So let me share with you a few examples of how these rare variants can really enable precision medicine approaches. And of course, it's hard to talk about a rare pulmonary condition without talking about cystic fibrosis. So we're going to do cystic fibrosis first. So as you know, cystic fibrosis is one of the most common genetic disorders in people of Northern European descent. And the disease burden of cystic fibrosis correlates perfectly with the carrier frequency of disease-causing variants within CFTR, because in those populations you can follow the Hardy-Weinberg equilibrium. Now, I would like also to highlight how the disease burden was greatly reduced by more than 5-fold with the aggressive neonatal screening program and prenatal screening programs implemented in Europe. Now let's contrast this with the Saudi experience of cystic fibrosis. So first, unlike in European countries where Delta 508 alone accounts for the majority of disease-causing variants, we don't have a single predominant variant from among the more than 40 pathogenic variants that have been characterized in the local population, right? Second, of the top 10 disease-causing variants in the country, they only account for 60% of the cases. And the meaning of this is, unlike what people think of our population being homogeneous, we're actually very, very heterogeneous when it comes to allelic heterogeneity. We see allelic heterogeneity wherever we look in rare diseases in the country. And the most frequent variant has a carrier frequency of 1 in 835, as opposed to 1 in 25 for the Delta 508 in Northern European countries. This is why, when some of our colleagues wanted to have a stab at the burden of cystic fibrosis in the country, they came up with an estimate of 1 in 80,000. And I would argue that this estimate is very, very inaccurate, because it assumed the Hardy-Weinberg equilibrium, when in fact, Hardy-Weinberg equilibrium is broken down by the phenomenon of non-random mating or consanguinity, which is very common in our society. And so the more appropriate way of estimating the disease burden would be using the QF method, where Q is the allele frequency and F is the average inbreeding coefficient of a country, which of course in our country is pretty high, 0.0241. And that results in an estimate of 1 in 7,000 almost, which is an order of magnitude higher than the one that's been estimated. So actually cystic fibrosis is pretty common if you look hard enough. The second example I'd like to share with you from a rare variant perspective is primary ciliary dyskinesia, or PCD for short. Now, PCD is a great example, A, because it's an otherwise very rare disease, but it gets to be more common in our society because of consanguinity. And B, because it provides a really beautiful example of precision medicine, as you're going to see in a moment. So as you know, PCD is a disorder of the motile cilia. And so if we forward here, yes. So it's a disorder of the motile cilia at the level of multiciliated cells, like the respiratory epithelial cells. And so this explains why you get impaired mucociliary clearance in these patients, but also monociliated cells, such as sperms with their flagella. That's why you get male infertility as a very common presentation. And also the embryonic node with the monociliated cells there breaking the symmetry of the early embryo. And so when that's impaired, you get laterality defects in these individuals. Now, the classical diagnostic approach to PCD is actually very, very complicated. And so we wanted to share with the wider field a different way of looking at it. So why don't we make it simple? And so we asked a very simple question. We asked our collaborating physicians to simply do exome sequencing if they have a patient with a suspected PCD. And so with this simple approach, we got really interesting results that I'd like to highlight as follows. A, just by doing exome sequencing, we were able to identify the causal variant in 75% of cases, which is really a huge success if you think about it, because the classical approaches, diagnostic approaches to PCD entail very sophisticated analyses such as electron microscopy and high-speed video microscopy that are not readily available to many people, whereas exome sequencing, you can just send a filter paper to a central lab that can run an exome sequencing for you. Second, just like I showed you with cystic fibrosis, where we have so many causal variants because of allelic heterogeneity, we see the exact same thing here. We have tremendous allelic heterogeneity of PCD in the country. Third, which I think is most exciting from a precision medicine perspective, is just how remarkable the phenotypic heterogeneity is of PCD. And so it's been a truly humbling experience looking at the phenotypic spectrum of patients with PCD. I mean, think about it. We're very biased as clinicians in selecting patients who we think are, they fit the bill for PCD or any other disease for that matter, right? Because we always have this preconceived notion of the textbook presentation of a disorder. And this is a very dangerous, biased approach that can really miss patients. And so what we discovered when we looked at our cohort, yes, of course, the original patients were classical PCD in their presentation. But once we identified the causal variant and we went to test their relatives to see who else is affected, we were very, very much surprised by the spectrum. So we identified individuals whose only presentation as adults was just recurrent sinusitis, and they were mislabeled as, allergic sinusitis. And we've had relatives whose only manifestation was male infertility that was assumed to be idiopathic. And lastly, what I want to mention about PCD is the fun of novel gene discovery, and I'll take you on a quick journey through some of these discoveries. So, for example, these two families each harbored a causal variant in a novel gene at the time. They're ANCA and Golgi A3, which we were able to show are highly expressed in the ciliated respiratory epithelium, as one would expect. And this is really exciting because not only are we now able to share a precise diagnosis with these families, we're enabling other families around the world to reach a diagnosis if they have pathogenic variants in these two genes. I think this is even a more exciting story. This story was developed in collaboration with David Sabatini and his group when he was at the Broad Institute. Story started with a Saudi family who was being treated at Mass General Hospital and for PCD. And so they did exome sequencing, and the exome sequencing was negative. And so my colleagues there contacted me and asked if I'd be interested in enrolling this family in our ongoing research program to see if we're able to identify a novel cause for their PCD, which we gladly accepted. And sure enough, we were able to identify a novel gene called NEC10, which we later found to be mutated in additional families. So this is now a major PCD gene that was identified primarily from Saudi families. Again, enabling countless families with PCD to benefit from this finding. Okay, I promise I won't disappoint you. I will touch on PAH. PAH, as you know, is a very rare disease. And so part of the challenge with PAH is, despite its rarity, it doesn't behave like the other rare Mendelian diseases. So yes, it's rare, 1 in 100,000, give or take, right? And yet, it's not like your other Mendelian diseases that I just talked about. For instance, less than 10% of patients with PAH would have a family history. And these are the ones that are likely to harbor Mendelian causes if you were to exome sequence them. So you can have a really high yield if you were to exome sequence them around 80 to 90%. Whereas those that do not have a family history, the hit rate of exome sequencing would be very modest. We're talking 20 to 30%. And if you look at the genes that cause PAH, this gene alone, the BMPR2, accounts for the bulk of the causal disease-causing variants in PAH. But there are almost 20 other genes that also can cause PAH. And what's unique is that almost all of them are autosomal dominant. And so I told you that we have the advantage when it comes to recessive disorders, not dominant disorders. So my expectations were pretty modest in making any real breakthrough in the genetics of this disorder until I was approached by Dr. Abdullah Al-An, who's not only an expert in PAH, those of you who know him, he's actually a very astute clinician with a very keen clinical sense. So he called me up one day and he said, Fauzan, I have this family with a strong family history, and I think they may have a novel autosomal recessive cause of PAH. So needless to say, I was super excited, and we did the things that I told you about, combining exome sequencing and positional mapping, hoping to identify a novel genetic cause of PAH. To our surprise, though, what we ended up finding was a homozygous truncating variant in GDF2. Now, GDF2 is not a novel gene. This is a gene already established in OMIM as a gene for hereditary hemorrhagic telangiectasia, or HHT. So the first surprise was Dr. Al-An confirmed that these patients do not have any of the HHT manifestations, only PAH. So that's a non-syndromic PAH presentation with GDF2. But that's not the end of surprises that came from GDF2. We found that this is actually a founder variant, a major founder variant in a specific clan in the northern part of Saudi Arabia, which allowed us to dig more, identify more individuals, and that allowed us to make more interesting observations about this, including the fact that the age of presentation is highly variable, including some adults who are completely free of disease despite being homozygous. And of course, Dr. Al-An is helping us doing very, very deep phenotyping to make sure they're not subclinically affected. And even more surprising was the fact that this is not a straightforward autosomal recessive variant. In fact, we identified several heterozygote carriers who also manifested PAH. And we're in the process of trying to figure out which risk factors probably influence the penetrance of disease. So this is a little teaser for what may be coming up in the next few months. So please stay tuned. So I'm going to spend the remaining few minutes switching gears from rare variants to common variants. And when it comes to common variants, as you can imagine, by their very nature, being very common, shared among people, they would be shared by individuals with the disease and individuals without the disease. Because remember, it's not 1 + 1 = 2 when it comes to common disease, common variants. They predispose to the disease. So you could have the variant and not have the disease. You could have the disease and not have the variant, right? And so the approach here is very different from what I told you for rare variants. And here the approach involves what we call genome-wide association studies, where you study a very large number of patients and a very large number of controls, and that's what it takes to achieve a statistically significant signal. Now, GWAS has been criticized for a very long time being irrelevant to precision medicine. I mean, after all, you want to individualize the risk of disease for your patient. I mean, it doesn't help when I give you an average over a large cohort, right? That's why everyone is excited by this revolutionary statistical approach to GWAS, which is called the polygenic risk score, or PRS. Now, what PRS does is that it combines all the data from GWAS into a score that allows you to individualize the risk of your patient who's right in front of you in clinic, to tell him or her you're high risk or low risk or intermediate risk for a given complex disease, be it, asthma or COPD and so forth. So this is wonderful, right? There is a catch though. PRS is derived from GWAS, as I said, right? So if GWAS has always been performed on Europeans, then you don't expect your PRS to perform very well on non-Europeans, as you see on this study, for instance. And this is why we had to invest heavily to optimize the polygenic risk score for the local population. And so what we did here was our first foray into optimizing polygenic risk score for the local population. We started with 10 cardiometabolic traits, such as coronary artery disease, diabetes, and so forth. And I'm very pleased to tell you that we were successful in optimizing them, and now they're ready for prime time. And I'm really excited to work with this community of pulmonologists to come up with ways to optimize a local polygenic risk score also for common diseases such as asthma, COPD, things that you'd be very familiar with. Now, I told you about the rare, I told you about the common, but there is a way to kind of straddle the line between them, right? And so this is called EWAS, or exome-wide association studies. It's a hybrid approach where instead of simply genotyping your patients and controls, you're actually sequencing them. You're exome sequencing them to identify rare variants that contribute to common diseases. And I think this is a beautiful example that I hope would resonate with you. I picked it specifically because you're pulmonologists. This was a very successful EWAS that was able to identify rare variants in TLR7, increasing your risk of severe COVID by more than 5-fold. So it's a terrific approach. Unfortunately, the problem is that it's expensive. So if you have the funds, definitely go for it. And finally, we can't talk about precision medicine without saying a word or two about pharmacogenomics. I think pharmacogenomics is a field with tremendous potential. Unfortunately, the data on its clinical utility remain limited, especially when it comes to cost effectiveness, although I'm sure the data will come online in the near future as more and more studies are performed. But there are exceptions to this rule. There are extreme examples where it's an absolute must to do pharmacogenomics. And as you can imagine, when it comes to cystic fibrosis, for instance, you can only prescribe certain treatments for cystic fibrosis if your patient has a very specific class of variants. So, towards the end, I'd like to remind you that despite all the things I mentioned, I only scratched the surface. Because remember, I only told you about genomics. And genomics is only one level of many, many levels of omics. There are the epigenomics, metabolomics, proteomics, transcriptomics, and so forth. So I truly believe that in the future, our patients are going to have reams and reams of both static and dynamic omics data integrated into their healthcare system in order to allow us to avoid the guesswork and provide them with the health care they deserve that is precise and individualized. So at the end, I'd like to summarize what I hope I was able to convey during my talk. Genomics is a really powerful tool, and I hope I've been able to convince you it's not a luxury anymore. It's indispensable to your practice. Anyone who's practicing in this region of the world has to be aware that there is a very high burden of autosomal recessive monogenic diseases. So please be on the lookout. If you have something atypical, think it could be monogenic disorder, and better be safe than sorry. I hope I was able to show you that genomics is a straightforward tool that could really democratize the diagnostic process for monogenic diseases. Stay tuned. for polygenic risk score for everything. I think this will be happening much sooner than you think, that your patients will be classified based on their polygenic risk score. And I'd like to remind you that genomics is only one layer of many omics that you will be flooded with in the near future. So we can really transform our medicine from traditional medicine to precision medicine. At the end, I'd like to thank all the members of my lab who made the work possible, all the wonderful collaborating physicians, some of whom were mentioned in my talk. Others I have been unable to include them in a single slide, and I truly, truly thank them for their collaboration. And thank you very much for your attention.
Thank you so much, Dr. Fawzan Al-Kraya, for this amazing, precise talk. Thank you so much for trying to simplify this for us, people who don't understand genomics. You did a great work. Thank you so much for this phenomenal presentation. So now, back to PH. It is my great pleasure to introduce our next speaker, our phenomenal, remarkable, I cannot find even the word, came all the way from Dublin to be with us today, Professor Sean Gain. Professor Sean is a pulmonologist. He is the director of the National Pulmonary Hypertension Unit, and he will be talking today about a year in review in pulmonary hypertension. And if you haven't heard Sean Gain speaking before, please listen and enjoy. The floor is yours.
Thank you so much for that lovely introduction, and it's lovely to be with you all again. Professor Adlan, thanks so much for the invitation, and Hassan for the logistics of getting us here safe and sound. It's wonderful, and it's remarkable to imagine all those people who've registered who are there online potentially. If we were nervous beforehand, we were a lot more nervous after finding out about how many people might be tuned in. So congratulations on a wonderful meeting. So I was asked to talk a little bit about the year in review, and here's just some of my disclosures to begin with. But I thought before we do anything, I'd start with this slide here. And the reason I wanted to do that was because I suppose as a clinician, I just love this picture. It's actually in the Tate Museum in London, and it's called The Doctor. And what's nice about it is it kind of gets us away from MRIs and echoes and right heart caths, and the things that take us away from patients sometimes and brings us back. There's the presence of the doctor beside the patient. That's the first thing. And the second thing in this is the patient, and in the background you see the family member. And that's kind of, I think, the world that we live in, but increasingly we perhaps don't. And we heard so much about precision medicine. Sometimes that can just seem like it's overwhelming when you're at the bedside with a patient, for both patient and clinician. But I was going to start there because it was a way of thinking the year in review. Because when I thought about that, there's many ways of looking at PH, the year in review. But I thought a nice way of doing it might be to look at it from a personal perspective as a physician, as a clinician in pulmonary hypertension, and then to think a little bit about what's new, what's happened last year for patients, and any new science that might be of use to them. So let's see how we get on. So I thought we might do it this way. You know, you see these things at the airport, you say whether you're happy or sad, depending on how you interact with the world. And I thought maybe we'd have a look at some of the data that's come out in the past year, and I'll give you a personal view of it maybe, and we'll also, as I say, have a look at a perspective of it with a patient with PH. Well, the first thing, I suppose, when you look back in 2023, it started well. And so we have a big smiley face for the 16th annual conference last year in Al-Kabar. It was a wonderful meeting, so that started the year off very well, as I think we are on this occasion. So I give a big thumbs up on the green man there on that. But actually, the truth be told, perhaps the biggest event from a clinician's perspective and from a patient's perspective last year was the New England Journal paper showing us that sotatercept reached its primary endpoint in a phase 3 study. And that was good news. What was even more interesting news, I thought, for sotatercept was that if we looked very carefully, the patients that were in the study and the ones who were getting benefit had the disease a long time. And I think we'd all agree there aren't really many options for patients who have the disease we can see on average 8 years. There aren't many things we can do for patients there. We're either going to transplant them, if they're not on prostacyclin at that stage, the chances that prostacyclin will dramatically change their disease 8 years into it is low. And so it was remarkable to see we were able to get 6-minute walk distance improvements with that. The other thing that was also very important was that so many patients were already on background triple combination therapy, and particularly including parenteral prostacyclins. So there were sick patients, and we were making a difference to those patients. So all good news all around for the beginning, and a big green smiley for that one. The big question, of course, is, were there any concerns? One of the concerns, I suppose, is telangiectasias and bleeding, but it seems to be something that hasn't really emerged as a major problem for the moment. We'll see when we get out into the long-term studies, and we'll see what happens in real life. It's going to be FDA approved and available in the US very shortly. The other one was its effect on the heart. There was some concerns earlier on in the phase 2 that it might have an impact on the heart. We had a paper looking at post-hoc analysis that I think was really comprehensive and showed us that, in fact, the impact on the heart doesn't appear to be anything other than good. We see improvements in coupling. The TAPSI-PAPSI score, for example, is improved. We see less tricuspid regurgitation. We see some diminution of right heart volumes. So overall, the message is good there. And that brings us to the next question, which is, where will we position sotatercept in the new guidelines? And you know, the World Symposium is coming up now in June, July, and it'll be interesting to see where that might happen. But actually, some people have already had a crack at deciding where it might go, and this was a very nice review by many of the experts in pulmonary hypertension in the Lancet this year, and they had a look at pulmonary hypertension, looking at progress in the disease and looking to the future. But they also had a look at what way a new algorithm might look like, and I think it's kind of an interesting one. In fact, in many ways, the first thought that I had was that we're looking at a 2-strata approach to risk almost in this, or maybe even one. And let me, if I might, explain that for a second. If you have a look, here you have the mortality risk. We think of it as 3 strata, but actually it's really 2 strata. If you're lower intermediate, you go on double upfront combination therapy. And if you're high risk, you go on triple combination therapy, including a parenteral prostacyclin. But then if you come to the first follow-up visit, they're suggesting lower intermediate risk, consider adding sotatercept, and if you're higher intermediate risk, consider adding sotatercept. And so I think it's very early days. I think that's perhaps a little bit of a jump too far ahead. There are other options that we have for patients that are not quite as expensive and don't have, you know, unknown longer-term consequences. But it does look that little bit like a message of it's there for everyone who needs it once you get past that first follow-up visit. That's not going to be the case in real-life clinical practice. Another bit of good news, I thought, was we're beginning to see phase 2 results come out, and the TORREY trial was a positive study with seralutinib. It showed that there was an improvement in the primary endpoint of pulmonary vascular resistance. Seralutinib works through a very similar pathway than we were used to with imatinib. And you remember from the IMPRESS trial back in 2013, it achieved its primary endpoint of improvement in 6-minute walk test with imatinib, but it had complications and side effects. And the general consensus was, if only we could get a better way of giving the drug, perhaps at a lower dose with less side effects, maybe something good would happen. And the other bit of news, of course, is that AV101, which is imatinib inhaled, is also moved on now to phase 3 studies as well. And so that's a little bit of good news in the world for patients with pulmonary hypertension coming up. And this is just to show that across all of the pre-specified groups, subgroup analysis, that the impact on PVR was good across all of the pre-specified subgroups in seralutinib. So a positive study. Let's see how we get on now with phase 3. But it wasn't all good news last year when it comes to drug studies. For example, there was a lot of excitement about radadostrat. The general consensus was that serotonin, we just needed to get the right drug to hit the serotonin pathway and we'd have impacts. But in fact, it didn't reach its primary endpoint of change in pulmonary vascular resistance, and it's no longer going any further for now. So another serotonin effort to target the serotonin pathway fails. This is another interesting study. You may remember from 2022, a lot of excitement that inhaled treprostinil in patients who had PH and interstitial lung disease, a positive study in the New England Journal with Aaron Waxman and his colleagues, and it showed that it was improving 6-minute walk distance, but also had positive impacts on forced vital capacity, and indeed so much so that the FDA has approved inhaled treprostinil as a treatment for these patients. And as you know, there's a great need for therapies for this group. But actually, I know there's going to be a debate tomorrow, so I have to be careful because Olivier Sipon and Steve Nathan are going to debate this issue tomorrow. But I'm going to throw in there a bit of disappointment I would have had is that when it came to the open label results that were published last year, you can see that the patients who were on the in the study did well, and they continued to have benefits in their walk distance in the open label. But the patients who were on placebo, when they went on the open label, they didn't get the benefits. So just, it's suggesting that a lot of the enthusiasm and excitement needs to be mitigated a little bit and controlled a little bit when it comes to inhaled treprostinil. We'll see more in due course, and you look forward to coming and seeing the debate on the topic tomorrow. I also thought this was a paper that came out last year, and I thought it was an important one just to mention. I've always believed that my patients take their drugs for PH. Why wouldn't they? It's a very severe, it's an incurable, nasty disease with a bad morbidity and mortality. But in fact, this was a meta-analysis looking at a number of different studies looking at adherence to treatment with, in pulmonary hypertension. Some were prescription-based studies and some were questionnaire-based studies. Well, what it came up with overall was around 60% of patients are adherent to their PH medications. So it's not 100%. And the reason I thought it was worth mentioning this particular study is that I think it may be worthwhile to consider that before we add or switch therapies, that we should actually focus a little bit on whether adherence occurs or not. So that study came as a bit of a surprise to me. Well, we heard a lot about precision medicine a moment ago, and I think that when it comes to omics, it has a remarkable future in pulmonary hypertension. If you think of the various different areas from genomics, epigenomics, transomics, proteomics, and so on, all of the data that we can gather together, things that we can measure, data integration, and then looking at what multi-omics can actually produce for us. And it may give us early diagnosis, accurate classifications, much better phenotyping, and so on, and risk assessment, and ultimately a better and personalized approach to medicine. But I suppose as a clinician, I can't help but still wonder, there's still a lot of fishing going on, and there's still an effort to kind of pull all that information together. And what I don't want to see happen is that we'll have to have the computer sitting beside us in our clinician and patient interactions in the future. But still, I have to say, I went through a lot of the data that's come out to see what's new in 2023, and I would say most of what's there right now is quite speculative, and therefore I didn't really include it for the year in review. But what I do think is there are some interesting areas that are coming out in the area of diagnostics. This is a very nice study from the group in Paris where they looked at a number of different cytokines. And they looked at those to see if you had cytokines that are associated with better outcomes, then maybe the more of them that you had, the better your prognosis. And actually, they found that was exactly true, that this is a patients at baseline, and then this is the patients who were in follow-up, looking at whether they had no low-risk cytokines, one low-risk cytokine, 2 or 3. And actually what they discovered was that the 3 cytokines, the prognostic value of those was actually more powerful for predicting survival than the non-invasive variables that we use, functional class, 6-minute walk, and BNP. So I think just the idea, therefore, that you might be able to get a blood test that actually offers more for your patient when it comes to prognosis than the walking down the corridor in patients that may or may not be able to do it, or indeed BNP levels that might change in response to diuretics is an exciting thing. So precision medicine is on its way, as we've heard, and it's coming in different ways at different times. Cytokines and biomarkers, I think, will be right up there as one of the first. I like this paper as well from our French colleagues because it just talks about CTEPH. CTEPH is in a remarkable disease area that so much has happened in the last while. And this was an interesting, just a little simple report. But what they were talking about was an area in CTEPH that's really hard to manage. Many of our patients have mixed disease. They have surgical disease on one side and they have angioplasty disease on the other side. Sometimes you can't find the disease except in one of the lungs, and what do you do with those patients? And so they went about this with a group of patients doing a sequential approach to treatment. And so they, if you look at them at baseline, they had very high pulmonary vascular resistance, and then they went and put on a PAH medical therapies, an ERA and a PD5 or a riociguat, and you can see that they get a nice improvement in their PVR across the line. And then they went and proceeded with BPA on the side that was perhaps more amenable to BPA. and then they followed up by a PEA, the actual surgical removal. And you can see this would be good for surgery, and this would be good for BPA. And you can see that across the board, they get the sequential improvement in PVR in response to a sequential approach to treatment. So the way we approach CTEPH is evolving, and I think even for those with more complex disease, there's hope there. And then the final thing when I was thinking about from a personal perspective in pulmonary hypertension was transplant. I just thought I might remind us all, and we were up at the King Faisal Hospital today looking at the wonderful transplant services that are there and the progress that's been made. And I always think about pulmonary hypertension. In the old days, when I started in pulmonary hypertension, you had to be a transplant physician and a pulmonary hypertension specialist because there was nowhere else to go, really. Prostacyclin was coming on board, but PH specialists were transplant specialists, and they were very much together. In fact, this picture is a picture of the first successful heart-lung transplant. It was done in Stanford by Bruce Reitz and Norm Shumway, and they carried it out on a lady who had primary pulmonary hypertension, IPAH. And she wrote a book sometime afterwards about her life, and she has it's I'll Take Tomorrow is the name of it, which is what all our patients who go for transplant think about. The story of a courageous woman who dared to subject herself to a medical experiment, the first successful heart transplant, Mary Gloak. And she lived for 5 years after her heart-lung transplant. So it was very much, PH was very much up in front in transplant. However, my experience last year wasn't so good. I lost a few people who were waiting for transplant, and I had some of my patients who were on the transplant list who were taken off that list. And so from a personal view, I just think that transplant is something that we're maybe getting the timing wrong of it as well. We leave patients, we're happy with them in medical therapy, we leave them go too long. And they're no longer safe, or people are getting, the anaesthetist or an anesthesiologist is uncomfortable about doing the transplant in those circumstances. So we really need to look at the way we list patients, I think, more carefully, because it's not there to the same degree as it should be. And in fact, the data would suggest that. This is just a paper from last year looking at whether or not some of the lung allocation score changes that occurred in the US had an impact on timing for transplant for pulmonary hypertension, but it really didn't. And what we know is that PH patients are less likely to receive a transplant and more likely to die on the waiting list than patients with parenchymal lung disease. So our patients aren't doing quite as well when it comes to transplant as they should. And this was a very interesting study, a very honest study came out just at the end of last year, looking at the UK and France, and looking at their outcomes for patients with PH. And it's busy enough, but just if you look over here, you'll see cumulative incidence of transplant. And this is in France, and this is in the UK. And both numbers are quite different. There's a lot more transplantation going on for patients with PH in France. Outcomes were very similar. This is in the first 6 months, number getting transplanted. But actually, if you look at how many patients that remain on the active list in both places, or how many are removed, it's really quite high. And so I just think it's worth making that point that I know in Ireland it's very similar to the system in the UK. Patients are waiting on transplant lists, they're not getting transplant, they're being taken off the transplant list, and it's something I think that really stood out for me in the year that passed. Okay, what about for patients? A story for patients and living a life with PH. Our patients are now, even though we don't have a cure for the disease, they're living longer. And they're living longer with a chronic disease. And so how can they live with that disease better? And they often ask that question when they're beginning their journey. They might say, what can I do to help my prognosis? And it is important that we talk about healthy lifestyle, exercise, nutrition, and so on, and adherence. But the data is lacking, but it's emerging. What about exercise? Well, last year there was a meta-analysis that looked at all of the studies that have come out so far in PH and exercise. And it showed essentially a large increase in exercise capacity, an improvement in health-related quality of life, and indeed a reduction in mean pulmonary artery pressure. So overall, the meta-analysis suggests that we should be considering exercise. In our own group in Dublin, we had a study that we published last year that was of interest. I think just to say, during COVID, it wasn't possible to bring patients in to do much when it comes to exercise. And we had a young postdoc at the time, Ciara McCormick, and she did a home-based. She sent patients out Fitbits, she sent out some exercise equipment, and she worked with them on Zoom, and actually was able to show that in a 10-week remotely delivered exercise program using a number of different components, that she was able to demonstrate improvements in quality of life, exercise, daily step counts, sleep duration, and many other things with really no adverse events. So it is possible to do these sort of home-directed approaches to exercise and pH. Anxiety and depression. Many of you will be aware that a couple of years ago there was a paper out by Karen Olsen and the group in Hanover showing that in patients with pH, they have significantly higher, pH is in blue and the background German population is in orange, they have a significant higher amount of major depression and anxiety in the background population. But what wasn't clear was, can you do anything about it? And a very nice paper, a systematic review by the group from the Pulmonary Hypertension Association in the UK, had a look at, well, what's out there? And they did a systematic review, which really showed there is nothing much out there. There are about 4 papers they could do their systematic review on. And it turns out that when you do intervene with various different psychological approaches, such as cognitive behavioral therapy or metacognitive therapy and so on, that they have positive impacts for our patients. So it's something I think that we should think about, and I'd leave you with the message on mental health issues, that maybe we should be focusing on that early on when you're making a diagnosis of a chronic disease for a patient, something they're going to have to live with, we hope, for 5, 10, 15 years, that they have at least a stronger base to build off from a mental health perspective. A couple of things in diet and nutrition. Everyone thinks that diet and nutrition will make a difference. The microbiome is a big deal nowadays. We talk a lot about it. We know that gut health is important, that if gut health isn't right, that you get this translocation of many chemicals, inflammatory mediators into the bloodstream. It can have effect on blood vessels. It can have effect on heart function. And there's quite a lot of interest in that area. When it comes to pH, there was a nice study from the Mayo Clinic group that was published last year, and really showing that they looked at healthy controls, they looked at family members of people who had pulmonary hypertension and patients with pulmonary hypertension, and showed that there was a pro-inflammatory microbiome in patients with pH. And not only that, that they found that they had a lot less diversity in the bowel organisms than their family members and indeed healthy controls. And you can see that there's actually a correlation between the diversity of the organisms in the bowel in patients with pH and their mean pulmonary artery pressure, and indeed with their pulmonary vascular resistance. So there's something there which begs the question, will we be in a position to impact upon that? Changes in diet, approaches to diet, antibiotics, for example, fecal transplants, many things that can be done in the future, maybe to reduce circulating inflammation in pH. And this is a nice paper from the group in Anton von Nodegraf's group in Amsterdam, and he was just looking at using an e-learning approach, a number of modules delivered online for patients, teaching them about nutrition, teaching them about fluid, electrolytes, salts, and then seeing what impact those who had the training module, what impact it had on them afterwards. And you can see that afterwards there was a significant improvement in many, many markers, but particularly health-related quality of life. So it's something I think, again, lifestyle intervention programs can make a difference to the quality of life of patients, and there are many ways of doing that. Home-based exercise, as I mentioned, but also e-learning protocols that are out there. One word on pregnancy, because it's probably the most difficult thing that we often do at the beginning of a journey with a patient, a young woman with pulmonary hypertension. And the data behind this has been improving and encouraging. And in fact, if we look that over the years, back before 2008, most of the papers talked about a significant infant mortality and maternal mortality. But since then, the papers are suggesting we're doing better and the mortality is reducing. And that's perhaps because we're choosing our patients more carefully. There are better techniques that we have to rescue patients in trouble, such as ECMO, for example. And we have better MDT approaches, multidisciplinary meetings to get patients over the line. But there was a report out last year from China, just to put some reality back into the situation again. The Chinese were saying that in their patients, and they looked at the different groups of patients with pulmonary hypertension, but if you look at maternal death, it's here in the red, the patients with IPAH, significant mortality still in that patient group. So I think the advice is still, look, pregnancy is something that we have to counsel patients against. There will be times that patients go forward against our advice, or by accident, other things can happen, but it is something that really is still remains, unfortunately, fraught. And then the final thing I thought we'd talk about a bit is monitoring. And this is an area that I didn't find that there's a whole lot has happened just yet, but I think it's going to. So it's by way of introduction, perhaps to next year. And we know from the CardioMIMS study, the device that's placed into the pulmonary artery to be able to measure real-time pulmonary artery pressures, In heart failure and preserved ejection fraction in patients who have the CardioMIMS in, there's definite evidence that you can impact on patients and have improvements in their pulmonary artery pressure when they have isolated precapillary pulmonary hypertension, or indeed combined pre and post-capillary pulmonary hypertension, with the use of the CardioMIMS device in place. And in fact, it may be that there's an opportunity to bring a degree of management through CardioMIMS, but also improve quality of life to patients, knowing what's going on real time away from the hospital setting. But why I wanted to mention it particularly is because there's a lot of interest at the moment in using these devices for real-time clinical trials. And there's a study in the UK at the moment, the Phoenix study, which is looking at patients with CardioMIMS and swapping them from riociguat to selexipag and back, and having a look at changes in therapy while you're watching them real time in sort of a safe environment of being able to know what's going on from a hemodynamic perspective without doing right heart caths all the time to find out. So there's also an interesting study they've been doing also in the UK looking at imatinib oral and looking at lower doses of imatinib than we'd seen in the IMPRESS trial. So just to say, monitoring may be important in the future from studies, but also for other reasons. And this is by way of describing the different ways that we can maybe take patients with a chronic disease and move them back home again, not have them seen every 3 months once they get to a stable part of their disease. We have phone-based follow-ups, video-based follow-ups. There are a number of different non-invasive approaches with Fitbits and so on, but also invasive like the CardioMIMS, and many other ways of following patients over time. And then taking an opportunity to pull the patient back in once we begin to see some red lines maybe that are close to being crossed. So I think overall it might change the subjective nature of that doctor and patient relationship, put in a bit of objectivity into that for patients. Your patient comes back to you and says, what have I been doing over the last 3 months? Well, you can tell them in those settings what they've been doing rather than them trying to remember the ups and downs that occurred. So it may bring some rigor to the doctor-patient relationship. So let me conclude there. That's my sort of personal and patient walk through a year in review. Just to start with looking at the year in review, it's often, there's a tinge of sadness. There are patients that we lose during the year, and I've certainly lost some last year, but also you get new patients arriving in and starting that journey all over again. And that will continue until we have a cure. We also have some very positive progress. We talked about sotatercept at the beginning, and we talked about the other phase 3 studies that are up and going at the moment, and positive phase 2 studies. Transplant was the one thing that upset me last year, and I just think we need to be better about that because people hold it out as such a great hope, but it's only there for a small number, and we need to keep it there for the people that it's there for. And then finally, I just say on the focus needs to move to living with PH. That would be my message from looking back at the year in review. It's a chronic disease now more often. How do we live with the disease? How do we change lifestyle? And how do we tackle mental health, exercise, and those sorts of things? There's very little data out there, but as you can see, it's beginning to emerge, how to live with PH long term. And I'll finish this is a small but selection of pearls from the year in review. I hope it will give some hope to you and to your patients along that journey with PH. And I think overall, when we look at where we're at, I think it was a good year. Thank you.
Thank you very much, Dr. Game, for an excellent review. At least some good news in the progress of therapies. It was an excellent review. Thank you so much. And I'd like to ask Dr. Fawzan also to join us up here. Abdullah tells me we have a few minutes for questions and comments.
Thank you so much for both speakers. I actually truly enjoyed both talks, amazing talks. Let me start with Fawzan. You know, we had this issue not with you in person, but with the results sometimes. So when we do the whole exome sequencing, we face these, you already touched base on this, these genetic mutation that you don't know if this is causing the disease or not. Now, is it appropriate if you have this gene positive, a mutation positive, and there is a family history also, strong family history, to just assume or just put in the report that this is hereditary pulmonary arterial hypertension? And what else you do, and I know you already mentioned this, but I want the audience to know, what else you do, and the magnitude of work you do to confirm that this actually is a disease-causing genetic variant?
So, as usual, a brilliant question from you, Dr. Dal'an. And believe it or not, this is a problem we grapple with a lot. These variants of uncertain significance, VUS, it's a major, major problem as we think of, we in genomics, we want to deliver what we can to you, for example, in pulmonology. How is it possible then that a big percentage of patients will be returned to you with VUS? What are you going to do with them? Now, the NHGRI, the National Institute for Genomic Research in the US, they predict that by 2030, believe it or not, we will not have VUSs. And the idea is we will have many approaches to tackle the problem. Some are going to be based on AI solutions. I don't know if you're familiar with something called AlphaFold. It's an AI-based modeling of proteins, and a new iteration of it's called Alpha Missense. So AI is trying to make sense of all these millions and millions of variants to predict that, yes, this is disease-causing versus non-disease-causing. So that's one line. Another line is what we call a MAVE, or a massive variant effect assays. And these assays will screen a very large number of variants in one go. So you can have a functional experiment that tests not only the variants you're encountering, but also variants you may encounter in the future. So you're basically saturating your gene with every possible variant that could occur, and you have the result up front. So this is accelerating very, very rapidly. And sometimes it comes down to the good old segregation. And again, if you look at how you classify variants, segregation is crucial. So if you do have a multiplex family with multiple affected, and your variant beautifully segregates, that's actually a very strong evidence supporting the pathogenicity. So you need to always talk to the lab with which you're working diagnostically to provide more information. As you provide more information, including segregation of additional family members, including the unaffected, that could help the lab upgrade or downgrade the variant to make it easier for you. So I'm sorry, we don't have a perfect solution yet, but we're working on it, I promise.
And another question for Sean. Thank you for the talk again. I know it's early to say, but since we are targeting now the pathogenesis pathway, what do you think it's potentially possible for sotatercept to be actually one of the first line of medication? Because now we are actually targeting maybe their modeling instead of treating hemodynamics and then adding sotatercept. I know it's just a triggering question. It's probably you don't have the answer for that.
I'll take this in a minute. Thank you, just for a moment. Yeah, I mean, I remember one of the things I learned many years ago about when I started in PH from an old mentor was try not to be the first word, but be the last word. And I think that way a little bit about sotatercept in some ways, in that I don't know that it's the first word of this new era. I think something else may end up being the last word, in that I think we're going to get better and better at doing what sotatercept does. We're going to get better at targeting the pathways, exactly as you say. We're going after activin, but maybe if we go after B rather than A, we might actually have less telangiectasias, and we hone in things a little bit more. We might have fewer side effects and be able to say, this is a straightforward enough, maybe we'll get it as a tablet. So I think there's something really exciting about it. The idea that we can treat patients with a disease on triple therapy who've out there a long time, I think is great. But I'm just a bit slow to get too excited yet. And the other thing, of course, is cost. It's going to be so expensive that it could be, I don't want to see PH become a disease any more than it is already of the rich and poor. So, we're hearing it's going to cost $300,000 per person per year in the US. I mean, that's crazy stuff. That's not what we want for PH. We want something that is there for everyone. So anyway, that's a long answer to, I suppose, that question. It's really exciting, but I think we need to be a bit more cautious about where we're to go next. And not to forget the drugs we already have. And that's a danger too. Some of the drugs we already have are no longer on that particular algorithm that I showed you, and that's not good yet.
Sean, very nice presentation. Thank you. I wanted to ask you if you think we're going to see return of hemodynamics. Now, the reason I ask you this is because, 10 years ago, 15 years ago, we were being told, repeat the cath, and then we went to non-invasive risk stratification. You didn't go into detail, but on that algorithm, it was suggesting that you might use hemodynamics to decide whether to add sotatercept. And then you brought up the CardioMEMS devices with the Phoenix study showing that you might personalize someone's therapy at that point when you either switch to Rio or you add in selexipag. So you might start to use hemodynamic monitoring actually in assessing a patient's response. So there's two examples from 2023 where we might start to be using hemodynamics in real time or at selected time points to manage patients. Are we going to see a return of this, or have we turned our back on hemodynamics and it's just for phase 2 studies only?
No, it's a great question, Luke, and I have to say, I think you're absolutely right. I think it was nice to get non-invasive approach to managing patients, and it's like a broad message, but I think if you go and ask all the PH specialty centers, most of them will do a right heart cath again very early on in the patient's course within the first 6 months to make sure they're on the right track. And even having someone, say a young 25-year-old woman who has IPAH, PPH, and they're low risk, are you happy enough with the functional class of walk and the BNP based on registry data, or would you prefer to make sure that that right heart has a normal stroke volume index, the right atrial pressure is normal, PVR is really down there, that you're not looking at someone with a PVR of 15 who's walking well and has a normal BNP. So I think we do it, and we have to be kind of careful that the guidelines tell us one thing and we're perhaps doing something else. We go precision per patient, and so I think you'll see it beginning to come back in the World Symposium approach would be to say, don't throw everything out. Let's start moving back a bit. I really think it will.
Thanks.
Thank you very much for the speaker's very elegant talk. So my question to Dr. Fawzan, I have to admit that genetics are not easy topics, let alone epigenetics and genes that are turned on and turned off. So I'm a program director of cardiology programs, and we have lots of residents and fellows here. So my question is, how do we incorporate personalized medicine into our current residency and fellowship programs? Practical advice.
Yeah, great question. I think the first step is to remove anxiety related with the word genomics when it comes to trainees. I think they need to be more familiarized with genomics. I do believe that doctors inherently believe in things that improve the care of patients. And let me give you an example. One experiment we did at King Faisal was to familiarize all staff with the power of genomics. And so we told everybody across departments, including surgical departments, believe it or not, if you have a patient that you suspect could be genetic, don't waste your time, just order exome sequencing. And the experience gained by that experiment was, really profound. People were very humbled by things they thought, oh, I really thought it was this, and turned out to be that, through the power of genomics. And that completely transformed an entire generation of physicians at that time, believing that I shouldn't be too biased by my clinical judgment. I need to be open-minded, knowing that I could be wrong, and omics can really help me. Of course, now we're talking about the level of very simple omics, genomics. As you said, there are so many other layers that are going to be integrated, step by step. But I think we need to take the first step now, familiarizing even medical students with the power of genomics. We need to teach genomics in a very practical manner as opposed to how we studied it for those of us who studied it at all. We need to make it very practical. We need to show them examples of how this is, real life. And it's, as I tried to mention, it's not luxury anymore. It's almost malpractice to see a patient and miss the diagnosis of PCD just because they think the patient has to satisfy A, B, and C, which we all know is now wrong. And if I were to tell you all the guidelines that used to be, you know, the name of the game in the old days, none of them are perfect. And we know that if we were to go by these guidelines, we'd be missing a lot of patients. So I think we need to increase access. In fact, I was just answering the question about the VOS and the prediction 2030 that there won't be any VOS. Another prediction is that genome sequencing will be as routine as CBC. It's in their bold predictions. I don't see us getting there that quickly in the local environment. We need to really push people to feel very comfortable ordering genome sequencing as much as possible.
Not only the trainees, the trainers need to be also.
Well, you said it. Okay, thank you. Absolutely, yes.
Again, we don't have access to this in all hospitals and centers. Genomic sequence for everybody.
So I don't know if others have heard. Apparently, there's a problem with access. My understanding is, okay, for example, the King Faisal Hospital system, they all have access. The military hospital, they do have access. I know the medical cities, King Fahd Medical City and all the medical cities, they do have access. The one that I'm not sure about is the Ministry of Health. And I know they're in talks with, I'm sorry. University should have access, I would imagine. Okay.
Okay.
Well, we'll have to talk then.
Because we're thinking maybe we can have access, like a special referral toward your center to get.
We can, but what I'm really trying to suggest is, I think the access needs to be universal. Everybody should have access to it because we need to make it an easy test. We don't want to make it complicated. I mean, you mentioned genomics and people are just, you know, they get anaphylactic shock.
We do.
But when it's available, like in our system, for example, it's in ISIS, you just click exome sequencing. You can even click ultra-rapid whole genome sequencing for emergencies. We want all hospitals to have this system in place. That's a goal.
Hopefully. Thank you. We still have one more question.
Yes,
please, go ahead.
Joanna Preston from Boston. Wonderful talks, both of you. I have a question for Dr. Fauzan that was sparked by your just last answer. Knowledge is power, and having our residents and fellows and young physicians trained to understand how powerful the knowledge of genomics is fantastic. The anxiety that I have encountered is from the patient side, and how can we educate and teach our patients to be open to the idea of being tested for a genetic mutation that they may pass on to their offsprings.
So I don't know what your experience has been like. For the most part, patients want answers. And if we tell them that this test is going to give you the answer, usually they have a very positive attitude. If you're talking about their anxiety about what to do with the variant, I think that's part of what we call pre-test counseling. And so in our field, we highly emphasize the importance of pre-test counseling. You don't want to order the test without telling the patient what to expect, because it's going to come back and haunt you. I mean, another thing, for example, that I didn't touch on, but it's important. If you do exome or genome sequencing, you could be identifying something completely unrelated to your patient's problem, what we call secondary findings, like think BRCA1 variant that causes breast cancer, for instance. You don't want to be dealing with this after the fact. You need to prepare your patient. Listen, this is something that could happen. And guess what? They have the choice to say, nope, I don't want to learn anything other than my disease. And that's totally fine, as long as you do proper pre-testing counseling.
Hello, my question's for Prof. Shongain. And I'm like, I would need to ask about like the Phoenix study. And how does like PA pressures reflect PVR? Because we're just, in cardiomems, we were just assessing pressures. And in heart failure, we're assessing pressure as a surrogate for volumes. So in PAH, it's a bit different. Pressures, they don't reflect PVR. You might have a better RV, then the cardiac index and output will be better with the same pressures, and the PVR will be even lower. So how do we put it in a clinical context of a patient?
Yeah, I mean, I think it's a really good point. I mean, in fact, you're saying putting in context for patients, but actually for people managing patients with pulmonary hypertension, I often get a call from a cardiologist saying, your patient is worse, their pressures are going up.
That doesn't mean anything.
Yeah,
it might be better because they have a better cardiac output and the PVR is lower.
Yeah, so I think it's very difficult when a disease is called pulmonary hypertension to debunk the prognostic value of pulmonary hypertension. And I think, yeah, to try and, with education, to move away from the number of the pressure and move exactly to say to the manifestations of how the heart is functioning, output, and what it's facing, pulmonary vascular resistance and right atrial pressure. But pulmonary pressures themselves, unfortunately, get everyone frightened for all the wrong reasons.
Thank you.
Thank you.
So we'll have 2 more questions. Prof. Mata, please.
Sean, one of the things you said really concerned me and actually shocked me, 60% adherence. And maybe I'm just deceiving myself, but I look at my patients and I talk to them, I don't think it's that low, and I could be deceiving myself. So do you think it's real based on your experience? And secondly, if it's that low in some studies, is it that they're not all the right patients that we're treating? There's a lot of patients treated with comorbidities and off-label. Is that the reason it's so terrible?
So that's a really good question. I have to say, I don't believe it either. And it's funny, I remember when I first discussed the results of this with Nazir Nagalia, he said, well, mine are 100%. And I said, well, have you ever studied it? And he said, no, I know this. And I think that's what we all feel. We all feel that our patients listen to what we say. But actually, the studies were quite good. They looked at who was picking up the prescriptions from the pharmacies, for example. Now, so sometimes you find that out that there's a delay in picking up. They miss it for a period of time. And I think it's more prevalent now. In the old days with prostacyclin, it couldn't occur because if you didn't take your prostacyclin, you died. But now with combination therapy, double oral, if you don't take your PDE5 inhibitor for a few days or miss your prescription runs out and you wait to come back up, you could probably hold on with a mono agent for a period of time without consequences to the same degree. But I like using this. I think it's provocative to take that data from the meta-analysis. 60%. Nobody believes it about their own patients, but it's a challenge to think about it. And it may be that they're not filling the scripts properly and they're almost afraid to say it. So that's how I look at it. More a challenge than a reality.
So, thank you very much. I'm delighted by both lectures, actually. For Dr. Sean, regarding the cardiomems, just a brief note and a comment maybe from your side. I think it's a bit early, and I understand it's a bit early for cardiomems to be used in pulmonary hypertension. My knowledge from heart failure patients, they're patients with significant pulmonary hypertension, i.e. in their criteria, transpulmonary gradient more than 15 were excluded. So how come we are bringing it back for primary pulmonary hypertension, for example?
No, I missed the beginning there.
Ahmed, what's the question?
So what I'm saying is that cardiomems, I think it's still, we're learning it, we are learning from it in the heart failure patients. What about pulmonary hypertension? When we know that most of pulmonary cardiomems studies in heart failure, the 3 major, patients with significant pulmonary pressure were excluded. Like, for example, they used most of the study transpulmonary gradient more than 15, they were excluded from their trials.
Yeah, that's going to be interesting to see. I mean, it really, you could be very pure about it and say that you don't really, in pure PAH, you don't really care what's happening as much to the PA pressure from what we heard before. It doesn't really matter as much. In left heart, you clearly do because it varies depending on the degree of left heart filling. And in fact, you could make a case that would make more sense to have CardioMIMS device in the right atrium or in the liver, so it would monitor right heart function better as the right atrial pressure goes up and down in response to changes in fluid. That might be more useful to us. But nevertheless, there still is a message there in people who have a fairly static left atrial pressure that you're watching trends over time. And in fact, the recent stuff that has been coming out of the imatinib trial is very, very exciting. You really do see changes in people. As soon as they go on drug, you see changes in their pressures. And you don't know what's happened to pulmonary vascular resistance necessarily.
you don't know what else, but actually it's matched by how patients are walking more or matched by what patients are telling us. So I was skeptical about what it might do, but I'm being quite convinced by seeing what's coming out of some of the studies recently.
May I make a comment on the CardioMEMS? I think the questions are very, very valid because we cannot rely on PA pressures who can go down when the patient gets better or go down when the patient gets worse, right? The CardioMEMS have the capability of measuring cardiac output. It's just that they have not been validated and approved by the FDA, but hopefully the newer generation will give us more information about flow so we can apply in PAH patients.
Thank you so much, everyone. And now we'll be concluding our session. I would like again, one more time, to thank our speaker, Dr. Kreia and Professor Sean. Thank you for being with us today. And for now, we will be calling our partners, PHA America, PHA Europe, and BVRI, please to join us and to greet everybody and just to introduce yourself. Thank you.
Abdullah, why don't you come up here, please, yourself?
Over there.
So Matt is our colleague from PHA America. We have to say America because Europe, PHA Europe is here, so but it's a PHA anyway. So they are actually somehow a new collaborators with SAPH, and this is the beginning of a journey of collaboration between the SAPH and PHA Europe. We have been, as you all know, partners with PVRI for many years, and the colleagues wanted to greet you, to introduce themselves, and on Saturday afternoon, they will have about 10 minutes talk each about what activities they do and how are they helping the patients and improving the awareness in the field of pulmonary hypertension. Matt, please.
Well, thank you everyone for being here to listen to my presentation, and thank you, Dr. Aldalan, for inviting me, and to Hassan as well. So I'm Matt Granato, I'm the President and CEO of PHA, and today I just briefly wanted to introduce you to PHA and how it all started. It really started around the kitchen table where 4 women met. They had this very rare disease, and they wanted to find camaraderie around, among themselves. They wanted to end the isolation, provide education, advocate, help advance research and PH science. So at the time they created what they call the United Patients Association for Pulmonary Hypertension. And since then, PHA has evolved into the largest PH organization in the world. Today we are a community of thousands of patients, caregivers, and also healthcare providers like you, and industry partners that work with us as well. We have over 3,000 active members plus thousands of subscribers. And I like to describe PHA as really a hybrid between a patient advocacy organization and also a medical society, because we do a lot of medical education, CME education, like here today. We're headquartered in Washington, D.C. We have 36 staff members and a budget of close to $9 million. And we kept that vision of those 4 women, and the patient is really at the center of everything that we do. All of our programs benefit the patient, whether it be our patient education or peer support, our advocacy, which is very important in the United States because we don't have a single payer program, our research. We have a registry, a patient registry with over 3,000 patients, our medical education. We have an accreditation program that I'm going to talk more about on Saturday, and our awareness to make sure that society knows about PH, and especially for early diagnosis. We know that PH is a race against time. So I invite you to come to the presentation on Saturday, where we're all going to talk about our programs and how we benefit the patients. Thank you.
Our colleague from BVRI.
Hello, everybody. Professors, thank you so much for the invitation. As you've said, PVRI and SAPH are old friends, and it's an absolute delight to be here today and to meet so many of you. So thank you for the invitation. My name is Karen Osborne. I'm the Chief Exec of PVRI. I haven't been in post very long, so this is a very quick gallop through our services. Our vision is to reduce the global burden of pulmonary vascular disease. And this won't work. There we go. And we do this in three ways. We advocate, we collaborate, and we educate. And I'm really proud of our education services. I think they're very, very strong, and I'll say a little bit more about those in a moment. Collaboration is very dear to our hearts. My colleagues mentioned that we're going to speak to you on Saturday, and I have two very specific requests of the delegates here. PVRI wants to collaborate with you, and I want to tell you more about that on Saturday. We've got a couple of projects we'd really like to work with you on, so collaboration, very dear to our hearts. Advocacy, we want to see pulmonary vascular disease acknowledged as a major global condition. We want it to be well understood, we want it to be well resourced, and we want to improve diagnosis and treatment and care. And as we know, I mean, we've got a long way to go globally to make that happen. So advocacy it's a work in progress still. Whoops. I've overshot. Okay, very briefly, PVRI is a family of over 6,000 specialists in over 100 countries. We cross borders, we cross country borders, we cross the borders of specialisms. We work with clinicians, with scientists, with academics, with pharma and industry, and with regulators. And when you get all those people together in a room, it is incredibly creative and collaborative and exciting. And we really do change things. I mentioned our education services. We run webinars. I don't know if anybody here has seen our webinars. They're monthly, cutting edge, free to view, and there's some really, really good science and some really good research going on there. So I would encourage you to have a look at our website and look at our webinars. We have some really exciting meetings, and we have an open access journal, Pulmonary Circulation. But one of the key things that we do is we bring people together. So SAPH was one of our geographic task forces back in the early days, doing some really, really exciting work, crossing borders, crossing country borders. We also have speciality task forces and work streams, bringing people together from all around the globe. And again, if you're here on Saturday, I would love to tell you a little bit more about that and see if I can engage you and pull you in to what we're doing. So that's it. An absolute delight to be with you here today, and enjoy the meeting. I'm sure you will. It looks like a really, really good program. Thank you.
PHA Europe.
So, my name is Hal Skåra, and I represent PHA Europe. And I would like to start by thanking you so much for inviting us here. It's a great honor for PHA Europe to be part of this great event. And also, I would like to thank all your physicians out there for the help that you're doing for the patients, because I'm a patient myself. So I was diagnosed in 2005, almost 19 years ago. I can see my beard is a little more gray since that time. I was diagnosed. I had a PVR of 8.5, so I definitely had PH. But I'm doing quite well after 19 years. And for me, it's very exciting to be here. It's a place I've never been to, this part of the world. And it's very exotic for a Norwegian to be in Saudi Arabia because it's so different. So the weather we have here, this would be the warmest summer day in my country. So this is PHA Europe, 37 associations. Some of them are actually outside Europe, as you can see. And when you look at our logo, you can see what we're all about. We're about early diagnosis. We want to create awareness so people can get diagnosed early. And then we want them to be on best treatment, to have better quality of life, and we want to help finding a cure. So I would love to invite you to come on Saturday and listen a little bit more about PHA Europe. Thank you.
Thank you so much, Hal. Well, I think it concludes this evening session. I'd like to thank you all for attending, and we are waiting for a very, very exciting program tomorrow morning. Please be on time. And the dinner will be served downstairs, just on your left side when you go down. Thank you so much.